that IgA nephropathy has new drugs. And, I go back to my training. I had to give a talk on IgA nephropathy, and there was really not much for me to share. I was sharing data that was 20, 30 years old. Nephropathy has new drugs. And, I go back to Okay, I thought I was hearing myself for a second. So I think that we're really in an exciting place in 2023, 2024 now. There is so much more to discuss. And, given the time, I think we're really going to focus on some of the newer data. And who knows, in a year or two, there may be even more to talk about. So the objectives of my talk today: briefly review the pathogenesis of IgA nephropathy and some of the known risk factors for disease progression. And then I'll discuss the available data on newly approved treatment options. And then, as mentioned, we'll have a panel discussion. So you all know about IgA nephropathy. You know it's the most common primary glomerular disease worldwide. And I'm not going to get into the epidemiology. But as we're sort of thinking through where we are in 2024, I just wanted to, sort of start with what are some of the challenges in treating this disease. And I think the first challenge for me, at least, is the fact that patients are often symptomatic and diagnosis is often made late in the course of disease. So urinalyses are not routine in many parts of the world. I know where I practice in Chicago, Illinois, a lot of young people do not get urine analysis at all unless there's a reason for it. And those who do, and microscopic hematuria is detected, that can often be ignored or misdiagnosed. So in women, often it's assumed that it's related to menses. Men are sometimes told that, maybe it's a kidney stone and they're sent down a workup of that path. But there doesn't seem to be enough, education around the fact that microscopic hematuria and, of course, proteinuria may not be benign. And then, as I mentioned, significant damage may have already occurred by the time an elevated serum creatinine is discovered. And the other thing to keep in mind in IgA nephropathy is these are often young adults or children in their second to fourth decade of life. And so, a serum creatinine of 1 in such a patient actually may be indicative of significant damage because their baseline creatinine may actually be 0.6, for example. So by the time a primary care physician notes a creatinine of 1.2 or actually acts on it by the time it's 2.0, a patient may have significant damage already. And then I think another challenge with this disease is the fact that the clinical presentation and the disease phenotype can be quite variable. So first of all, not all patients are biopsied, and perhaps this is a missed opportunity. Patients that have microscopic hematuria without proteinuria, for example, or very low-grade proteinuria, may not be biopsied and they may be treated empirically. Patients present differently. So some patients have that classic episodic gross hematuria that presents after a viral infection, and others have persistent microscopic hematuria, whereas you can imagine those with the persistent microscopic hematuria and no other symptoms may be recognized much later in their disease course. As mentioned, the degree of proteinuria can be variable. So unlike some of our, classic nephrotic syndromes, these patients may not be presenting with edema. They may show hypertension, but they may have, lower grade proteinuria. They may have moderate proteinuria. And again, whether that's being detected or not really depends on whether urine analyses are being performed. And then the disease trajectory can be quite variable, which is another challenge with IgA nephropathy. So some patients may present at a normal eGFR and stay there, whereas others have what at least I was taught was slowly progressive CKD, and others may have a rapidly progressive glomerulonephritis. So no one follows the same path, and I think that is something that makes treating this disease more challenging. And hopefully some of the data I'll show you during my presentation will focus on the fact that we really need to pay closer attention to this. And then, as I mentioned, there were very few treatments available for decades. Part of that may have had to do with an incomplete understanding of the pathophysiology of IgA nephropathy and not really truly understanding what the lifetime risk is for patients. I think a lot of people thought that this was a more benign disease compared to some of the other glomerular diseases, and I would encourage people to change how they think about this disease. Hopefully, my talk will help with that change in framework. And then there is, of course, drug development challenges and rare diseases in general. So, if you have a large trial looking at chronic kidney disease patients with thousands and thousands of patients, you can have a number of events, and you don't need to have a trial that goes on 10 or 15 years to be able to see outcomes. But in rare diseases, this is a challenge because, you have fewer patients with the disease that are being enrolled, and it takes longer for you to see outcomes. And fortunately, we now have some new approval pathways that have changed how drugs can be approved in the rare disease space, specifically in IgA nephropathy. And that's really led to a resurgence in interest by pharmaceutical companies in this disease, and ultimately has been a huge win for our patients. So that's what I'm going to focus on in the next few slides here. And again, this is probably not new to this audience, but over the years, the pathogenesis of IgAN has really sort of solidified, and what's most widely accepted at this point is this 4-hit hypothesis. And what that really refers to is the fact that there, in a genetically susceptible individual, there may be a number of factors that perhaps make this patient susceptible to developing this disease. There may be alterations in gut microbiota. There may be aberrant mucosal immune responses. We know that infections are classic triggers. Food antigens may also be one of the underlying causes. And ultimately, something triggers the increased production of galactose-deficient IgA, which is really the hit 1. And that leads these susceptible individuals to develop autoantibodies to that galactose-deficient IgA, which can be of the IgG or IgA subtype. Those autoantibodies combine with the galactose-deficient IgA, forming these pathogenic immune complexes, HIT3, which then travel into the kidney and deposit specifically in the mesangium, where they then can cause inflammation, glomerular injury, and lead to a number of pro-inflammatory and pro-fibrotic pathways, including complement activation. So this is really, I think something that it's fairly widely accepted at this point, and leads to the question of where are we working to target the disease? Are we really focusing on all the different areas, or have we traditionally only been focused on one particular way of treating IgA nephropathy? So if you take it back to, the patients you're seeing in clinic, and I will say that over the years, I have really accumulated a lot more IgA nephropathy patients, and some days I'm seeing a couple at a time. But if we think about what does this mean for our patients, I think there's a few considerations. One thing is, we know we need a kidney biopsy to diagnose the disease, but does that biopsy only tell us about the fact that they have IgA nephropathy, or does it tell us more? Does it actually inform the prognosis? And then what factors are associated with higher risk of disease progression? I mentioned the heterogeneity of this disease, and so we need some guiding principles to help us figure out who do we put on therapy, and what should those therapies be, and what is the risk-balance ratio? And then finally, can treatment really mitigate risk while minimizing adverse effects, right? Because at the end of the day, we want to make sure our patients are compliant. We want to make sure that we're reducing, proteinuria and prolonging or preserving GFR, but also wanting to make sure that patients can tolerate the medications that we're prescribing them. So just something to keep in the back of your mind as we go along. And in talking about risk factors and deciding what are the things that we should be looking at to risk assess our patients, this is a very famous trial from the Toronto Registry back in 2007, which really showed that renal survival was inversely correlated with proteinuria. And so if you look at renal survival here, and you look at time on the x-axis, what you can see is that over time, the greater degree of proteinuria you have, the poorer your renal survival. And this is time average proteinuria. And the sort of inflection point that was noted here was patients who had less than a gram of proteinuria for the most part, had 80–90% renal survival, even out to about 15 years, whereas those who were nephrotic, their renal survival may have only been 50% even at 5 years. So this was, I think, really important for us to recognize and change the way that people thought about focusing on proteinuria reduction. This was back in 2007. And now we have newer data in 2023 from the UK Radar Registry. And what we're finding here is that maybe less than a gram is not good enough. So this was a retrospective study of over 2,400 patients who were high risk of progression based on proteinuria or GFR, and they were followed for an average of 8 years. And what you can see here is that even those with lower grades of proteinuria, this would be equivalent to about half a gram per day, still had pretty substantial decline and lower survival from kidney failure than we probably traditionally thought. In fact, the mean age of kidney failure in this cohort was only 48 years, which I think is quite astonishing. So now this is 2023. We've learned a lot more about proteinuria, and I think after we see this data, we are really thinking about the fact that we need to try to decrease proteinuria to as low as possible. But at the end of the day, we're nephrologists, and what we also really care about is GFR. So what I'm showing you here is a heat map from the UK Radar paper, and you see that this is patients reaching kidney failure here in these various colors, and then you have annual GFR decline, and then you have age groups down here at the bottom. And what you can see is that you really need to work on reducing your annual GFR decline if you want to have any sort of chance of saving your kidneys and not ending up on dialysis or needing a transplant in your lifetime. So if you look at a traditional IgA nephropathy patient who presents, let's say, in their 30s and 40s, and they have a 2 ml per minute decline in GFR per year, they have an 80% chance based on this cohort of reaching kidney failure during their lifetime. And I think that is really unacceptable in this day and age, and we know we can do better. So what else can we use outside of looking at proteinuria and GFR? Many of you may know about the International IgA Prediction Tool, which was developed by Sean Barber and the International IgA Nephropathy Consortium. And this is a really great tool that you can actually get on your smartphone. It's only to be used at the time of biopsy, so that's an important thing to know. But it allows for characterization of patients into low all the way to highest risk. It's not meant to determine whether you should treat someone or exactly how you should treat someone, but I do think it provides useful information. And this is the website if you want to take a look. But ultimately, you just need a little bit of data that you have at the time of biopsy, GFR, blood pressure, proteinuria, age, race. You can do it without race as well. And then your MES-C score from biopsy, as well as some of the medications. And then you're able to predict what the risk of disease progression is up to 5 years. So with all of these tools, I think it's a really exciting time where we're moving from the Stone Ages to the New Age in IgA nephropathy. Many of you may be familiar with the 2021 KDIGO guidelines, and I will just say that we're in 2024, and these guidelines were actually outdated already by the time they were published, because this is how rapidly this field is moving along. But in 2021, or prior to that, ultimately what the guidelines remind us is that there are no validated biomarkers in IgA nephropathy. We really do need a kidney biopsy to make the diagnosis. And what they recommend is that we use that International IgA Prediction Tool to help in shared decision-making when we're talking to our patients. They really recommend that we work on enrolling patients in disease registries. In the US, for example, we have CureGN and Neptune. And the more information we have, we can consolidate that and hopefully, do work in biomarkers, genetics, and omics and others. And then the recommendation is to start with maximizing supportive care, and that includes blood pressure management, maximally tolerated ACE inhibitor ARB, and lifestyle modification. And then KDIGO shows us this algorithm for patients that are high risk despite the 3 months of optimized supportive care, which is defined as proteinuria greater than 1 gram per day. And again, I just want to say that I think we're going to be changing that target given newer data that's emerging. But they ultimately recommended as first line for patients who are higher risk enrolling in clinical trials. And as someone who has focused a lot of my career on clinical trials, this was very exciting for me. It's also the reason why we have new therapies in IgA nephropathy. So I think this was a great idea. And then for patients who perhaps were not eligible or were not interested in a clinical trial, they stratified based on GFR what the next steps were. And therapy was considered, and then again, this is 2021, if you had low GFR, considering maximal supportive care, and that's really based on data that came from the STOP IgAN trial. And in patients who had a GFR greater than 30, if you risk stratified them and you felt that they, were a good candidate for glucocorticoids, that would be individually considered. And that was based on the 2 testing trials that were published. So this is where we were in 2021. And then there was a turning point. And based on a joint effort by the FDA and ASN, there was the Kidney Health Initiative that really led to a change in how we were looking at clinical trials and clinical endpoints in IgA nephropathy, and proteinuria was determined to be a surrogate endpoint in trials of IgA nephropathy, which meant that there could be a new approval pathway, and patients didn't have to be in a study for 10 years, but really could be in a study for a shorter duration and be able to get new therapies on the market. So with that, I'm going to show you some of the new trials and the new data that led to approval of certain medications. So here we have just a diagram showing all the different new molecules, and there's probably some that are missing here. And we're going to go into a couple of these with the time we have before our panel discussion. So first of all, SGLT2 inhibitors, which all of you know and love. The DAPA trial, or the DAPA-CKD trial, had a pre-specified analysis for patients with IgA nephropathy, and there were actually 270 patients with IgA nephropathy enrolled. Ultimately, the composite endpoint of the DAPA-CKD study was looking at 50% decline in GFR, end-stage kidney disease, or cardiovascular death, and they compared dapagliflozin to placebo in patients who were on an ACE or an ARB. Now, a couple things that I want you to keep in mind when you're looking at this study, and I want you to keep this in mind as I show you some of the future studies, is that this was not a traditional IgA nephropathy study. So these were patients enrolled with chronic kidney disease with a GFR down to 25 up to 75, and their proteinuria could have been anywhere from 200 milligrams to 5,000 milligrams. But this is a bit different than, say, a phase 3 clinical trial in IgA nephropathy. The patients needed to be on a stable maximum tolerated dose of ACE inhibitor or ARB for about 4 weeks prior to enrolling in the study. And there were patients that had diabetes as well, although the majority of them with IgA nephropathy did not have diabetes. And what you see here is that when you compare dapagliflozin to placebo, overall, looking at the composite endpoint and the composite kidney endpoint, it was in favor of dapagliflozin. I mentioned a couple of caveats about how this study is different from other IgA studies. The other caveat I want to mention is that these patients were older and had a lower GFR than what we typically see in some of our phase 3 studies for IgA nephropathy. So just things to keep in mind, but overall, as you can see here, we're looking at GFR as well as UACR data, dapagliflozin versus placebo. You can see that the GFRs, were stable in both groups throughout the 36-month endpoint. And then if you look at UACR placebo compared to dapagliflozin, you do see that dapagliflozin reduced proteinuria or albuminuria in this case that was sustained throughout the course of the study. Okay, and then the ANCA kidney trial, which you also know has been recently published, in dapagliflozin, similar study. There were patients with lower GFRs. And again, the composite outcome was cardiovascular renal death need for dialysis or kidney transplant or sustained reduction in GFR. This was quite a large study with over 6,000 patients, and I'm not going to get into the details of this, but just to show you, there was not a pre-specified analysis for IgA nephropathy patients, but here we do have a table looking at patients with IgA nephropathy. There were about 800 patients, so quite a few, around 400 in each group, and you can again see that the data favors empagliflozin compared to placebo with a hazard risk of 0.67. Again, keep in mind this is an IgAN cohort with chronic kidney disease. So, in addition to SGLT2 inhibitors, one of the major trials that led to new therapy being approved in the US and as well as in Europe and other places around the world was the study for targeted release budesonide or Nefecon. And this is based, this molecule has the postulated mechanism of action that I wanted to go over for those who are not familiar. So targeted release budesonide or Nefecon is really meant to have two features that are important. One is the fact that it's pH dependent, and the other is that it's delayed release. So the thought is that you take this molecule, you take this pill, and it goes and acts on the Peyer's patches in the distal ileum where we believe that there are an increased number of galactose-deficient IgA producing B cells. And so the thought is that, you may be targeting the source or one of the sources of galactose-deficient IgA. And one of the other reasons this drug is thought to be beneficial is that it has substantial first-pass metabolism through the liver and theoretically may have fewer systemic corticosteroid effects. So this led to the NefIgArd trial, which was a phase 3 international study. There were over 200 patients with IgA at the time point of this study, or the interim here. In the entire study, there were 364 patients, and patients were randomized to Nefecon versus placebo. They received treatment for 9 months, and then they had a 3-month follow-up off therapy, and then an additional year after that where they were monitored. The primary efficacy endpoint was their 24-hour UPCR at 9 months, and this is a little bit harder to see. I'll show you some of the longer-term data, but ultimately, Nefecon did meet its primary endpoint and compared to placebo, and I will show you that on the next slide here. So here we have the entire 24-month period. Nefecon here is in blue and placebo in red, and we're looking at the percent change in UPCR from baseline. So you can see that Nefecon had a greater decline in proteinuria even out to 12 months. And then this is the data from 9 months all the way to 24 months. Patients were not on therapy, they were just followed. At the 12-month mark, the percent change from baseline was 51. And then by the end of the study at 24 months, there was still a difference of around 30%. And then when looking at GFR in this study, you can see that Nefecon attenuated the GFR decline that's typically seen in patients with IgA nephropathy. And when you look at the 24-month data, the absolute change from baseline was -6 ml per minute per year in the Nefecon group and -12 in the placebo group. So looking at the safety profile, especially when you're considering how this may compare to systemic corticosteroids, remember that this study was compared, Nefecon was compared to placebo. What I want to point out is that you're always worried about infection risk in patients who are on steroids, and you can see here that the number of cases of nasopharyngitis and upper respiratory infection in Nefecon versus placebo were actually quite similar. Some of the more common side effects that were seen were peripheral edema and hypertension, but overall very well tolerated. And this, is now an FDA-approved drug in the US. It's also approved in other places, which is really exciting. It's one of the first, or is the first FDA-approved drug for IgA nephropathy. So next I'm going to talk to you about a dual endothelin and angiotensin receptor antagonist, or Sparsentan, which has also received approval in the United States and accelerated approval in Europe. So Sparsentan is a really unique molecule. It is one molecule that I want to point out. It's not two molecules in one. And what's unique about it is it blocks both ETA as well as AT1. So this part of the molecule here is responsible for affinity to angiotensin, and this part of the molecule here is responsible for affinity to endothelin. And so with one molecule, you're actually targeting two pathways, both the angiotensin 2 pathway and the endothelin 1 pathway. And this is just to show you some of the overlap and some of the differences in what these molecules target. I think as nephrologists, we're very comfortable with angiotensin 2. We may not be as familiar with what endothelin does, but as you can see, it's actually involved in more than just vasoconstriction, but it's involved in mesangial cell proliferation, glomerular sclerosis, and a number of different actions on the podocyte. So this was thought to be a molecule that could possibly target two different pathways with one, and was being tested in FSGS and in IgA nephropathy. I will show you the data from the PROTECT trial, which is shown here. This was also an international phase 3 clinical trial that was double-blind. And the unique thing about this trial is that Sparsentan was compared to an active control, irbesartan, not placebo. Again, these were high-risk patients with IgA nephropathy. There was around 400 patients enrolled. And I'm going to show you the data on the next slide. So here you have the data for the proteinuria reduction. You have irbesartan here in the light blue, and you have Sparsentan in red. And you can see that not only was proteinuria reduced in Sparsentan compared to irbesartan, it actually occurred fairly quickly. There was almost a 40% reduction within a month, and that proteinuria reduction was sustained throughout the 110 weeks of the study. And the primary efficacy endpoint was the 9-month proteinuria reduction, and that's what is currently being utilized for accelerated approval in the United States, and led to Sparsentan being available for use in the US. And then for the eGFR data, which is the secondary endpoint, or the secondary confirmative endpoint, what you can see here is, again, you have irbesartan in the light blue, Sparsentan in red, and you're looking at the least mean square change from baseline GFR out to 110 and then 114 weeks. And there's both chronic and total slope recorded here. You can see the Sparsentan group, the slope decline was minus 2.7 for chronic, compared to minus 3.8 for irbesartan, leading to a between group difference of 1.1, which was clinically significant. And then for total slope, it was minus 2.7 versus minus 3.9, which was a p-value of 0.05, which just missed statistical significance. When you look at the forest plots, which to me visually are a little bit more helpful, you can see that whether you look at chronic or total slope, Sparsentan was favored in all of the different analyses that were done. And then when looking at safety profile, I know this is a busy slide. You can take a look at this in more detail in the Lancet paper. But, you know, I would say overall similar in terms of things like peripheral edema. There wasn't a signal for that, 15% in Sparsentan versus 12% in irbesartan. Hypotension, 13 versus 4%. The one that gets discussed quite a bit is LFTs because of, in the US, the REMS program. But what you can see is actually only 5 patients, go back. Very similar, and very few numbers of patients in both groups had AST or ALT elevations, and there was no hepatotoxicity at all in the PROTECT trial. So I think that was very reassuring. Okay, we're almost to the end here. So I've shown you now some of the approved drugs for IgA nephropathy, but there's a lot more coming. And here I'm showing you some of the phase 3 clinical trials. We talked about NefIgArd, which is now approved at least in the United States. Protect, so Sparsentan, which is also now has accelerated approval in the United States. The Artemis trial, unfortunately, is no longer moving forward, but we do have a number of studies that are moving forward. The Visionary trial, which is an anti-APRIL drug, Origin, which is an anti-APRIL, anti-BAFF drug, atacicept, and then Applause, which is a complement inhibitor that inhibits factor B, iptacopan, a hard time saying that one. And then the Align trial, which is looking at atrasentan, which is an endothelin receptor antagonist. So there is going to be a lot of data. Some top-line data has already been published for some of these trials, and a lot more coming this year. So stay tuned. And I'm just going to end with a few unanswered questions as we go forward. So what's the right drug for the right patient at the right time? With multiple new therapies available and more on the way, how will we know what to start with following RAS inhibition? And given this is a heterogeneous disease, do we need to do more? Do we need to interrogate tissue? Do we need to test and validate biomarkers? I think the answer is yes. And then what's the optimal treatment paradigm? We need to balance efficacy with safety. With different mechanisms of action, I don't think a blanket 9 months is the answer. And I think we need to think creatively about how we're going to approach our patients. And then lastly, how do we define goal-directed IgAN treatment? I think we need to think about the differences between clinical remission of proteinuria versus histologic remission. Should we be looking at a multi-targeted approach, and which new therapies are safe to combine? And should there be maintenance therapy in IgA nephropathy as we do in other glomerular diseases? So with that, I just want to thank you all for having me. I know we're going to have a discussion after this, and I'm going to go ahead and turn it over, but I'm happy to take questions.
Thank you so much, Shikha. That was a great talk. Thank you, everybody, for these amazing questions in the chat. We actually have a couple of cases, and maybe we'll just start with one case. Our panel for this talk are, as I mentioned, Dr. Wadhwani, Dr. Javeri, and Dr. Alexander. And so we'll start with the case. Some of these questions are actually relevant to the case, so I'm going to sprinkle them in as we go through the case. So we'll, if you don't mind sharing your slides again, Dr. Wadhwani.
Oh, yes.
Thank you. Sorry, we put them all in one
Sorry,
slide.
I did. I forgot that. Okay. Can you see my slides?
I can.
Okay.
Perfect. So I'm going to go through this case, and I'm going to sprinkle these questions in for our panelists, our amazing people here. So this is a 48-year-old Indian man who is referred for hematuria and 2+ proteinuria that's discovered on urine dipstick. Your past medical history is there of hypertension, and the patient is on losartan 25 milligrams daily. No allergies, but does occasionally take alcohol, no drugs, and is not a non-smoker. The BMI is 23 and blood pressure is 130/84, and the rest of the exam is completely normal. On labs, the estimated GFR is 68. Your urine analysis shows 15 to 20 RBCs per high power field, and you have the 2+ protein that we saw already, and a UPCR of 1.7 grams per gram. The serological workup is negative and a kidney biopsy is done. On the biopsy, you see mild to moderate mesangial and endocapillary hypercellularity and mesangial expansion. Your IF shows predominantly mesangial IgA 3+, and you have some kappa, lambda, and C3 that's there. And you have some electron dense deposits in the mesangium. So your MES score was M1E1. Okay. So can we go back for a second? So now this is the patient that you just biopsied, and you talked about, let's do a risk assessment, and you did the IgA risk prediction tool. What do you do next, right? Like, you're here, what should people here do next? Anybody? And then how can we make it better? Dinar, Cecina.
Sure. So I can, basically, you do have that risk prediction tool that kind of gives you an idea, at least for 5 years, at least tell the patient and the family that what the progression is of kidney disease. I think if you put it in the calculator, maybe around 7% progression of drop in GFR over 5 years. So at least they have some idea that what's going to happen to their kidney disease. It takes into MES score into account, hypertension, age, couple of factors that you showed in your presentation, Shika. I mean, to me, that doesn't tell me what how I'm going to treat the patient. Personally, I look at the MES score. That's why I do a lot of biopsies, because I think if it's active, which means that the M and E are present and less of S and T, then I really want to treat with immunosuppressive or disease-modifying agents. If it's more S and T, a more sclerotic and more IFTA, maybe I should focus more on the patching up drugs, like the non-disease modifying agents. And we have both approved now, similar drugs, in both categories. So that's the way I think of IgA, similar to rheumatoid arthritis, where you have disease modifying agents that are slowly coming out, and steroids, budesonide might fit in disease modifying agents, MMF. And then you have the non-disease modifying agents, such as Sparsentan, ACEs-ARB, SGLT2 inhibitors, that really are more in the long downstream, more of fibrosis, anti-fibrotic effect. So that's the way I would approach this patient.
Okay, so if we go to the next slide, this patient was already on a RAS blockade, right? They were on losartan, it's up-titrated, the blood pressure is stable, but your urine protein is still 1.5. So, Cecina, what are you going to do now? And then also we have questions about what's available in India. So what would you do now?
Yeah, thank you, Koel, and good evening, everyone. So as Shika had pointed out, the main step for the treatment of IgA is maximize non-immunological therapy before we consider disease-modifying agent. In this respect, for the previous question, I would just like to add 2 points. One is the international IgA nephropathy equation has not been validated in Indian population or a South Asian population. And there are at least 2 cohorts, one from our own center, which is a longitudinal IgA cohort of incident biopsy-proven patients. And there is another cohort from AIIMS Delhi. And both of these cohorts, we have reported that the the international IgA nephropathy patients under the equation underestimates the progression of renal disease in the South Asian population. So we need to understand that our population might be having a more severe presentation and a more rapid progression. The second point that I would like to highlight is about the MES score. Most of the clinical trials, they don't go by MES score except excluding the T2 and the C2 lesions. Now, even more trials are not even looking at the MES score. They just are going by the IgA diagnosis and the eGFR and the UPCR criteria. What we have seen in our follow-up is that though it generally, the T2 score correlates with low GFR, many a times because of the focal nature of the renal biopsy, it may be that many patients have a higher GFR, but they may have a T2 lesion in biopsy. So to completely decide a disease modifying or any other treatment in IgA based on a T2 lesion is not evidence-based as of now. Now, coming to non-immunological therapy, of course, what KDIGO guidelines go by is to maximize RAS inhibitors and to with 2 goals. One is to have a goal BP of less than 120/80. And the other goal is to lower the proteinuria as much as possible. So here they have maximized, and the urine protein by creat ratio is still 1.5. So in the next slide, I think you have the options. Koel, can you show the next slide? Yeah. So these were the options that are available right now for us. And going by the current evidence, which is the DAPA-CKD and the EMPA-CKD studies, the dapagliflozin falls into non-immunological therapy. So it could be that we can add dapagliflozin to a maximally tolerated dose of ARB and follow up and see the reduction in proteinuria before we start a disease-modifying agent. The other pathway is to encourage enrollment in clinical trial, especially if the GFR is more than 30, which is so in this case.
That's great. So I'm going to actually combine a couple of questions from the chat, right? So just keep in mind, this may be your question getting answered. We're combining agents, right? Should there be head-to-head trials between this combination? What do we know? Is a combination, for example, of ACE inhibitors or RAS blockade with SGLT2 better than RAS blockade by itself? Or should we be combining with budesonide and with, or I should say, targeted release formulation, Nefecon? But how are there head-to-head trials? What should we do next? Let's say your proteinuria is still high.
Yep. I'll take that question. One is to maximize the non-immunological therapy. So you have an option of starting SGLT2 on a maximally tolerated dose, or at least a 50% more, greater than 50% of the maximally labeled dose of ACARB. That is the traditional way in which you will approach. And usually you add on SGLT2 at least after 4 weeks of starting a RAS inhibitors, because you need to watch for the decline in eGFR. Now, to combine a disease-modifying agent like a budesonide or a steroid along with dapagliflozin, most of the clinical trials right now add DMARDs on a maximally tolerated dose of RAS inhibitors. But more and more trials now are allowing a steady dose of dapagliflozin during the screening time before we add the disease-modifying agents. What we don't know right now is what are the adverse events, especially when you give immunosuppression and dapagliflozin together, because already in the dapagliflozin trials, one of the major adverse events was the occurrence of urogenital infections, which is concerning, especially in a diabetic population or a population which receives immunosuppression. So these are unanswered questions. Yes, there is a need for head-to-head trial. Thanks, Koel, for bringing this up, because we are planning a head-to-head trial in India with many multi-center academic trials all across India, which will start recruiting soon on most of the available disease-modifying agents that are there in India.
And before I get to Kinar for a question, I just have a quick question. Is Nefecon available in India? And if not, are you using an enteric-coated budesonide, just so that our listeners are hearing that?
Yeah, that's a good question. So Nefecon, as that has been tested in the phase 3 and the phase 2 trials, are not available in India. So Nefecon is actually a targeted release budesonide, and they use something called the target starch capsule technology. This technology allows it to target the maximum dissolution of the tablet happens at the terminal ileum and at the proximal colon, where there is a highest density of pair patches, which is where the B cells are lodged for the production of galactose deficient IgA1. The formulations that are available in India are more like a controlled release formulation. They are pH dependent dissolution. So what happens is they don't dissolve in an acidic pH, but as soon as a pH is more than 6, which is what happens throughout the intestinal tract, the tablets dissolve. So you have a budesonide formulation in India, almost all of them. The dissolution happens, though it happens in terminal ileum and proximal, it happens throughout the intestinal tract, even up to the sigmoid. So that is a major difference between the two molecules. We have limited experience with this formulation in India. There is one retrospective, there is one study from Romania, if I'm not wrong. It was by Ismail et al. They have a small RCT which they have done with this formulation. They used about 9 milligram of budesonide for 12 months, followed by 3 milligram for 12 months. So for total duration of the trial was 24 months. And in that, they compared it with oral corticosteroids, and they did find some benefits, which was more than the oral corticosteroids with minimal, with tolerable side effects. Other than that, we have one prospective cohort, but again, it is not an RCT and it is an open label cohort, which had shown reduction in proteinuria in eGFR, but since it's not an RCT, I cannot comment much about it. So we don't have any rigid data about this formulations for IgA nephropathy in India.
Inara, I have the next one. I have next couple for you before I go to Shikha, if that's okay. This is all about Nefecon, essentially. Just basically, what is the GFR cutoff to start Nefecon, first of all? And then if it's not systemically absorbed, why do we see side effects? And then the last one is, why do we see a slight increase in the GFR in the trial? But you can go in whichever order, and I can repeat them.
Well, thanks. So a couple of things before even on what Sukina was mentioning. The regular budesonide or generic one we do use for IBD, right, in the US, and it comes in 3 milligram tablets, I believe, not 4. Yep. So you actually, can give those to patients. People have given it and have seen similar responses, despite it being more colon as opposed to just the ileum. So we don't know. We just don't know because it was never studied from the generic form. It's more studied in this more targeted form, like Sukina mentioned. So really don't know. And most of these studies are GFR about over 30, and you can't really get, approval for, lower GFRs yet. A lot of these patients we do see much earlier to give these steroids. The thing is, they are still steroids. So have I seen patients on IBD who are on budesonide with adrenal insufficiency? Yes, I have several patients. So it is still a form of, it might not be that systemic. It still gets some absorption. Remember your anti-VEGFs that you give for intravitreal, they still cause TMA. So it's intravitreal, very small doses. This is much more than that in your gut. So there will be some absorption causing hypertension, acne, some degree of adrenal insufficiency if you get dependent on it, I think. So despite it being local, it might be a good amount of absorption, but definitely less than oral steroids. I think, though, maybe you'll give Shikha some chance to talk, because she gave some of these, trial details. Anything else you wanted to add to those questions, Shikha?
Yeah, Shikha, about the GFR decline increase.
Oh, yes.
Especially.
I think it's not uncommon with corticosteroids to see that slight elevation. Or you mean the slight GFR increase is what you were talking about at the beginning? Yeah, I don't think that's uncommon with corticosteroids. And, I think that with like SGLT2 inhibitors, RAS inhibitors, we see that slight decline and then it comes back up. Overall, I think you have to decide what are your options, right? So first, I think making the first decision is, are you focused on non-immunologic therapy and proteinuria reduction up front? If so, what does that include? Does that include RAS inhibition? Does that include SGLT2 inhibitors? Does it include endothelin receptor antagonism? Like, what does that sort of foundation look like? And I'm really excited to hear about the new head-to-head trials they're going to be doing in India to give all of us more information. And then I think the next step is, if you do decide you want to add more to that, something that is immunosuppressive, what is that going to be? And depending on where you are and what's available to you, that may include, low-dose systemic corticosteroids, that may include a budesonide formulation. It may include going into a clinical trial to help get other drugs on the market. So I think, though, my concern is waiting 3 months, what we should be doing. I know we need to maximize our foundational therapy, but as Susaina mentioned, if you look at the cohort in India, she can speak more to this than I can, but some of these patients have a 5 ml per minute decline per year in GFR. And when you look at the UK radar registry and the fact that we need to really lower that to less than 1 ml per minute per year to keep patients off dialysis, I think I'm just in general thinking about being more aggressive up front and not necessarily adding RAS and then adding SGLT2. And then, by this point, we're 6 months into it and we may have lost time and lost nephrons. Again, we don't know which patients are necessarily going to be the highest risk or the most likely to progress. There's a lot of things that go into that, but I think that I'm at least moving towards being more aggressive up front.
That sounds great. And one other question was, have we now changed our goal UPC to be less than 500 milligrams? What are you all practicing? What is our goal UPC in these patients now?
I'll be interested to see what everyone else has to say, but I'm definitely looking to target at least 0.5, if not 0.3 in terms of treatment. I think the question is, what's your target UPCR to start additional therapy? And then what's your target to get the patient down to? And I think those can be different. So for me, definitely if they have over a gram of proteinuria, I'm going to be doing something. Even if they have more than 0.5 gram per day, I'm probably still going to want to do something more. But I think my target is to get it as low as possible and ideally less at 0.3 or less if possible.
Okay, so I do the same after the UK study that just came out, the RADAR trial. I think even patients like Shika showed, proteinuria of less than 0.5 progressed over 30 years to end-stage renal disease. So I would get to 0. Like, why have any proteinuria? If we can lower it as much as possible. Unfortunately, no trial design will allow a patient above like 0.7. It'd have to be at least minimum 0.75. It's hard to get data outcomes with 0.5, 0.4 baseline proteinuria. So that'll never probably happen, but I think data from retrospective studies have shown that the lower we go, the better.
So it's there's so many great questions in the chat, which is hard to answer in this time frame, but do you think—
I think, Goyal, we can answer, some of us can start answering that on the chat, like while the next session starts, so we don't, go out of time. Is that okay? Either between Shika, Sukina, and I can answer some of those questions on the chat.
That would be actually perfect. Thank you so much. One last question that I'm going to ask you all before we move on to the next session then is, we say macroscopic hematuria has better prognosis than microscopic, and then but we also talk about proteinuria, and this whole proteinuria discussion, we've forgotten about macroscopic versus microscopic. Does that still play a role when proteinuria is controlled? Hard question. Do we even know?
I nominate Susaina to take this question.
Can you just repeat that once more? I was just typing an answer in the chat box.
Sorry, we confused you. If you have, we say macroscopic hematuria has better prognosis than microscopic hematuria, right? Persistent microscopic hematuria. But now this whole world of proteinuria discussion, what if you still have microscopic hematuria? Is like, does that still contribute a higher or worse prognosis, and why so?
Yeah, so the literature as of now says that even microscopic hematuria over a course tests potent a poor prognosis, more because it tells you that there is an ongoing chronic inflammation. Macroscopic hematuria being prognostically better is probably because of 2 reasons. One is that you detect the disease early because you have a visible gross hematuria and you come to the doctor's clinic fast. The second may be because it is an intermittent shedding. So usually it happens with a synpharyngitic illness. So it's an intermittent shedding with no chronic sequence, so sequelae, which could be the 2 reasons why you have a better prognosis with intermittent macroscopic hematuria. And about the budesonide, sorry, I just wanted to just highlight that more than the efficacy of the tablet formulation in India, The things that we don't know about it is the adverse event, especially when it affects the entire intestinal tract. Are we looking at more parasitic infections, especially in a tropical country like India? And do we have the same side effect profile as the Nefecon tablet? These are the more worrying questions.
That is such a very important point. Thank you so much for making that. I'm going to pass on this to Dr. Bansal, who's going to moderate our next session.
Yeah, thank you, Shikha. Thank you all the panelists for a very, very useful and important discussion. And we now move on to next session. For the next session, Dr. Koel Jain, she's the speaker of the session. She's already introduced, distinguished teaching professor and associate professor of medicine, University of North Carolina, US, where the first classification of the vasculitis came out. So, and she's also the educational committee chair of the International Society of the Glomerular Diseases. Dr. Duburu Gita, she is the professor of medicine in Johns Hopkins University, Baltimore, and she has special interest in vasculitis, especially ANCA vasculitis, and she conducts clinical and translational research in vasculitis, and she has been part of the KDIGO guidelines also. And we have another panelist, Professor Aman Sharma. He is a professor of the clinical immunology and rheumatology at Postgraduate Institute of Medical Education Research, which is one of the most prestigious institute of in India, and he has started the first vasculitis registry of India. He's a rheumatologist, and he's also the president-elect of Indian Society of Nephrology. So we start the session. I invite Koel, please, to share her presentation.
Let me see, sorry. Are you all able to see my slides?
Yes.
Okay, thank you so much. I had all the Q&As were open. Well, thank you so much, everybody, for joining in and listening to us today. I love anything and everything to do with vasculitis. And when I made these slides, I realized I made too many slides. So try to cut it down. We'll talk a little bit on the basis of certain cases that I would want to highlight and talk a little bit about ANCA vasculitis. I will briefly mention the classification and we'll talk a little bit about the standard treatment. And then we'll move into the discussion regarding the role of plasmapheresis and then steroid-sparing therapies. And what do we do, right? We've been actually at UNC when I finish my steroids by 4 months or earlier sometimes. And so what are we doing to actually finish steroids earlier and be sparing with steroids? And only if we have time will we go into infection-related vasculitis. I am the site PI for LDL apheresis, which is with Kaneka, but that's for FSGS, and I don't really have any relevant conflicts of interest with this talk. And then just for patient privacy, I've changed information regarding the cases just so that you won't be able to identify any of those cases. Okay. So we just met together, and Dr. Jeanette was telling me how many decades ago, the first international Chapel Hill classification consensus had come out. And then 2012, they realized, there's a change in the nomenclature that needs to happen. And this was the new nomenclature that you can see. You can see my laser pointer. So what they decided was they actually separated out the immune complex small vessel vasculitis and the ANCA vascular disease, which was then divided into MPA, microscopic polyangiitis, GPA, granulomatosis with polyangiitis, which was previously known as Wegener's, and then EGPA, eosinophilic granulomatosis with polyangiitis, also known as Scherk's-Ross previously. And one thing that I've seen time and time again in my patients in clinic, and I see a lot of vasculitis patients, is ANCA-associated vasculitis, even though it's a small vessel vasculitis, it does actually involve medium vessels. So you can see this whole box going from medium vessels to small vessels. So don't be surprised if you have a patient who has a small vasculitis involvement, but also has some medium vasculitis, medium-sized vessel vasculitis, because that can happen with ANCA vascular disease. So there was a recent update that came out through ACR and EULAR, and basically this was more for research purposes. And once a patient is diagnosed with vasculitis, how do you really know they have GPA, MPA, or EGPA? There's really a lot of overlap that exists there. So they came up with this scoring criteria, classification criteria, if you may. And what they said was for patients with GPA, they actually give scores for different involvements, right? So nasal involvement, cartilaginous involvement, lung nodules, or a PR3, right? All of these things were getting a positive certain amount of points. And then if they had eosinophils, for example, right? That probably is not GPA, that's probably eGPA at that point, that actually took away points. You don't, obviously, this is not something that anybody is quizzing you on, but just to keep in mind that GPA was sort of classified this way and not really to diagnose patients. This is after they were diagnosed with vasculitis. And anybody with a score greater than 5 was probably going to have GPA in these patients. And I thought, even though this is for research purposes, sometimes it's very hard for us as clinicians to say, GPA, MPA, or eGPA, and this is really helpful to me. You would say it really doesn't matter in treatment, which is true, it doesn't. But to be honest, for insurance purposes, if you're listening in from the US, our medical insurances will only take the diagnosis GP or MPA for patients to get approved for drugs. For MPA, basically, what really stands out is for me is obviously the MPO antibodies that are positive, but also the lung involvement is not really nodules or masses, but more fibrosis or ILD that you're seeing. So those are the scores that you're really seeing in these patients, including a post-immune GN. And if you had a score greater than 5, then again, they were classified as MPA and not GPA. eGPA, I think we sort of know this already, somebody who has obstructive airway disease. So you remember the patient, we talk about asthma, somebody who has eosinophil count that's high, or maybe neurologic involvement. Those are the patients more likely to have eGPA. Okay, so that's sort of the classification of vasculitis. But before we head into all the controversies surrounding treatment, I actually want to share one case with you. So this is a 60-year-old female with a history of hypertension who presents with seizures, fatigue, arthralgias, left arm and foot numbness, and nighttime low-grade fever. So all of these are real symptoms that I've had in patients. The physical examination at that time was unremarkable. There was a little bit of numbness at the base of the feet and the toes, but otherwise, by the time we saw her, it was unremarkable. The baseline creatinine used to be 0.6 and is now at 1 milligram per deciliter. Your urine analysis shows greater than 100 RBCs. And on urine sediment evaluation, while we don't see any CAS, we see 25% of these RBCs had dysmorphic features and were acanthocytes. The PR3 ANCA was really elevated at 100, and our cutoff is less than 21 at our institution. So got a kidney biopsy in this patient. And what you can see in this light microscopy is, the stuff is sort of crushed there because you have this crescent that's developing here. And you can see all this fibrinoid necrosis that has happened already. And then this patient has post-immune lining up basically on immunofluorescence. Okay. So the question then becomes, how do you initially treat this patient, and would you plasmapherese her? I'm not gonna ask our panelists just yet, and we can talk more about it later in the interest of time, but I want to give you like 3 seconds or 4 seconds. This is your patient. Would you pherese her? Just think in your mind, like 3 seconds. Okay, I think 3 seconds are up. Before I get into what we did and go into the data, I want to tell you the KDIGO guidelines. So the KDIGO guidelines that literally came out fresh in 2024, this year, and this is only the induction portion, not going into the maintenance portion, is that once you have ANCA-associated vasculitis, right, you really need to determine whether this patient has organ-threatening disease or organ-threatening disease or life-threatening disease or no organ-threatening disease. If there is no organ-threatening disease, which is the left side of this graph, then you could use either rituximab or cyclophosphamide-based therapies. And the new addition to this was that you could use steroids or avacopan in these patients. So either one of those. But if you had life-threatening disease or vital organ-threatening disease, and your creatinine was greater than 3.4 especially, they actually now recommend rituximab and cyclophosphamide combination, which is what we've done for now a very long time and have found really great results in these patients. And I'll go through it a little bit in detail later. You could also use cyclophosphamide by itself. But remember, in both of these, cyclophosphamide is actually preferred for patients who have life-threatening or vital organ-threatening disease, as opposed to just rituximab only therapy. And again, you could use avacopan versus steroids. There's still recommendation to consider plasmapheresis in the right patient. And I'm hoping by the end of this section, you'll be able to formulate which patients probably need it. So this patient initially didn't get pheresis, right? The creatinine had gone up to 1, had all these symptoms, got actually steroids and cyclophosphamide, but about 2 or 3 weeks later, she was readmitted with a creatinine of 4.5. So now the question is, the creatinine has gone up, it's an organ-threatening disease, and would you pherese her right now? So before we go into what happened to this patient, I'm going to show you some of the data that exists out there. One of the earlier trials that we had in plasmapheresis was the MEPEX trial. This MEPEX trial came out in 2007, and what they did was they took patients who had ANCA vasculitis and really bad kidney function. Creatinine was really high. And they gave one group plasma exchange, and the other group got methylprednisolone. Both of them got steroids, oral corticosteroids, but one group got only IV steroids along with it, and one group got just plasma exchange. And what they noted was 1 year mark. At 1 year mark, patients who got plasma exchange were less likely to need dialysis, right? So if you got plasma exchange, you were less likely to be on dialysis at the 1 year mark. People then looked at the long-term follow-up of the MEPEX trial, and they actually did not notice much of a difference. The hazard ratio crossed 1. However, as per any statistics class, even though it crosses 1, it really does favor that there's a potential benefit for pheresis if you look at that confidence interval. People then looked at meta-analyses for all the PLEX data that existed. This is published back in 2011, so we've not come to the recent trials yet. And even then, there was a question whether this pheresis may be favoring pheresis may be favoring giving pheresis to patients with life-threatening disease. Well, then everybody was waiting for actually a big randomized control trial, which was our Pexivas trial that came out in the New England Journal in 2020. This was a huge trial, right, for vasculitis, 700 patients who had severe ANCA-associated vasculitis. Now, what does severe ANCA-associated vasculitis even mean? This was anybody who had an eGFR less than 50. So anybody, whatever, whether it was an AKI, whether it was CKD, anybody who had a GFR less than 50 and had lung hemorrhage, essentially. The Pexivas trial was looking at 2 different outcomes. One, whether plasma exchange works or doesn't work, and whether we could use standard dose steroids or reduced dose steroids. I will actually come back to the steroid portion of this exact trial later on in my talk, but we're going to focus on the plasma exchange portion right now. What you can see here is there's really no difference. Whether you did plasma exchange or you did not do any plasma exchange, it really wasn't any different between the 2 groups. So a lot of people were disappointed, essentially. But they did show a 1 year follow-up, which showed a potential for benefit. Again, the same thing with the confidence interval, that it didn't really show a statistically significant difference, but a potential for benefit at the 1 year mark for plasma exchange. There was a lot of controversy that happened with the Pexivas trial, and there were a lot of limitations that people had brought out, right? One is, like I mentioned, eGFR less than 50. You and I, or most of us, know this already. Somebody could be presenting with an eGFR of 40, but their normal GFR, baseline GFR, was actually 90, right? They've dropped drastically to 40, as opposed to somebody who's been at a 40 GFR for a year or 2 years for whatever reason, right? So not knowing what the severity of that injury was or how much scarring had already happened was really a big limitation of the study, that we did not have histologic data. People looked at the subgroup analyses for pulmonary hemorrhage, and there was, again, a potential for benefit in the pulmonary hemorrhage group. But the other problem was we didn't know how many people died of lung hemorrhage. We don't know how long did it take for the hemorrhage to resolve. And so it really wasn't designed to figure out those factors. So it left many people just saying, I'm not going to do plasmapheresis for whatever reason because the Pexivas trial said so. But in reality, you have to think about the limitations. Maybe there's a group of patients who will benefit for pheresis, and we'll talk about that. So the meta-analysis that was done in 2011 needed to be updated, right? So Dr. Walsh's group in 2022 decided to update that meta-analysis, and they only included the more recent randomized control trials, and which actually showed a potential benefit to actually doing pheresis, and it reduced the risk of end-stage kidney disease at 1 year mark. So probably does benefit in reducing need for dialysis. However, it did increase the risk of serious infections, which we know pheresis can takes away your antibodies and does immunosuppress you. Okay, so far, a lot of the controversy had been regarding histologic data being missing in the Pexivas trial. So you know what? The French vasculitis study group said, we're going to look at histology and see if that really helps PLEX outcomes. Okay, so we're just going to focus here for a second. This was a retrospective trial, so not a randomized prospective control trial. And they looked at patients who had acute kidney injury. They divided patients between the ones who got pheresis and did not get pheresis. And they were looking at 1 year, did you die? Or did you need any sort of dialysis or kidney replacement therapy, right? What they noted was the pheresis group or the PLEX group was not actually better than in terms of primary outcome than the no pheresis group. But there was a caveat, and this was a huge deal with this study, is they actually were able to identify the patients who benefit from pheresis, which means that pheresis as a blanket therapy does not help everybody, which is what they proved. But they actually were able to identify criteria, which is on the right side, which would help identify the patients who would benefit from pheresis. And they used in this histologic criteria. So the BRIC score and the burden score, which are used by nephropathologists and were sort of used in this criteria, gave a score threshold of 7. So if you have a patient whose score threshold was greater than 7, they were more likely to benefit from pheresis. In fact, in those patients at the 12-month mark, the absolute risk reduction was 25% approximately. So 1/4 of the patients would actually benefit and not have death, essentially, or need dialysis. That's a huge benefit, but only in a certain section of patients. So people decided to validate the score. And, if you think about it, who would need pheresis? Only the patients who are not going to do well, they should get pheresis, right? And who are going to die should get pheresis, as opposed to somebody who's going to do well regardless. Why would I pherese somebody who's going to do well regardless, right? And they were able to prove in this validation cohort that the pheresis recommended group or the PLEX recommended group did have worse outcome, right? So, and the score actually did predict poor outcome. So if you use the score, you could predict poor outcome, and you're more likely to benefit from PLEX in that treatment group. Okay. So if you're not totally confused by that, we'll get to some take-home points. But before that, okay, kidney function, what about hemorrhage, right? Where does pulmonary hemorrhage play a role in all of this? Just going to focus here for a second. This is the same data as the PEXIVAS data. And they just did this analysis, and it actually came out as a publication this year. And we looked at only the patients who had diffuse alveolar hemorrhage. So they just took those patients, and that was 191 patients. They also pulled out from that 191 patients how many had severe diffuse alveolar hemorrhage, which was only 61. Okay. They noted the ones who got PLEX, 8% of those patients died at 1 year, as opposed to 15% of the patients who did not get PLEX. So if you look at statistical analysis, I mean, it's hard to argue, right? Almost half the patients, 8 in the PLEX group died, as opposed to 15 people in the non-PLEX group, but they still crossed 1. And the problem was that this had a very small section of patients who required ventilation, or they had very few patients who had severe diffuse alveolar hemorrhage. But you cannot deny the fact that has a potential for benefit in somebody who has severe diffuse alveolar hemorrhage. Just not powered to figure that out. There were no changes in the ventilator-free days. The other problem was also that the bronchoscopy for these patients was not required. So what may have been thought as basically having hemorrhage may have not been hemorrhage and may have been another issue. But overall, the takeaway was from this study, or the subgroup analysis, was if you have pulmonary hemorrhage, especially if it's severe pulmonary hemorrhage, and by that I mean you're ventilated, or you have an oxygenation or saturation of greater than less than 85% on room air, probably would benefit from pheresis. So this was a patient. What did we do? Well, we actually had given her cyclophosphamide initially, and then we actually gave her pheresis and steroids and cyclophosphamide again, because the 2-3 weeks was almost at the next cyclophosphamide mark. She got azathioprine initially, and then she had some recurrence and got some rituximab. Creatinine has now been stable at 1, even a few years later from this treatment of this patient. So the take-home points is, if you have a severe acute kidney injury histologically, and you do not have a lot of scarring, and you're not dependent on dialysis for a while, you may actually benefit from pheresis, right? So it's not that every patient should not get pheresis. If you have severe pulmonary hemorrhage, which means less than 85% oxygenation or saturation, I should say, on room air, or the need for a mechanical ventilator, maybe benefit from pheresis. And then I didn't go into this, but if you have anti-GBM disease and you have ANCA Vasculitis, that's a no-brainer, right? Anti-GBM disease, you should give pheresis in those patients. Okay. So moving ahead, this is case 2 and 3. I'm going to go through it quickly. This was a 48-year-old patient who basically presented with what looked like ENT vasculitis and had septal biopsy, which diagnosed this patient with sinus-limited ANCA vasculitis with a PR3 ANCA that was high. This patient was initially started on steroids and MMF, but could not tolerate MMF despite changing it to myfotic version of it. And then with steroids, could not tolerate that either, requiring lots of ED visits. So steroids was a problem in this patient. And then the third patient also, this one actually had lots of GPA flares essentially, and actually had developed strokes from GPA, and they could not taper up their prednisone. They did not know whether they were taking 40 milligrams today, were taking 20 milligrams the next day, were taking 60 milligrams, lot of problems, and were now having steroid side effects. So with both of these cases, I think the main issue was, how do we get off steroids? Like, what can we do to spare steroids? Not going into this, there's a lot of side effects from steroids. So we really want to be sparing with steroids. I'm going to leave you with a few things as to what trials have shown can be done for steroid sparing effect. Well, the Pexavas trial is the one that we talked about already. And the secondary aim was to try and figure out whether reduced dose steroids, still pretty decent dose, but reduced dose steroids were non-inferior to standard dose. And what they realized was, as compared to standard dose patients, the reduced dose steroids had similar death or end-stage kidney disease, and the reduced dose was really not inferior to standard dose. So you could do reduced dose steroids. And in fact, your infections were less in 1 year. This was the dosing that they used for reduced dose steroids. And obviously, you can't memorize all of this, but the main point was, this is the reduced dose, is that they actually reduced the dose after the first week. On the second week, they almost halved it. So if you were on 50 milligrams, you went to 25 milligrams, 60 went to 30. So they almost halved the dose. And by around the 16-week mark, you were down to almost 5 milligrams of that dose. So you had come down really quickly on that steroids as compared to the standard dose therapy. Okay, another trial, which looked at 140 ANCA patients, and they all got rituximab as their induction therapy. They actually got reduced prednisolone, which was 0.5 mg per kg in a day, versus high dose prednisolone, which is 1 milligram per kilogram per day. And in these patients as well, they actually noted fewer side effects with the reduced dose. Now, I know that these two lines look like they have diverged, but it really happens that their y-axis is so spread out that there looks like there's a divergence. But in reality, the composite outcome was really no different between the two, which included relapses, end-stage kidney disease, death, or first serious adverse event. And the survival was also similar in both the groups. So technically, both these trials show that you can use less steroids that we've been using so far. The next strategy was this avacopan, right? This was groundbreaking for ANCA vasculitis. This is a small trial that initially came out before the Advocate trial. And they looked at new or relapsing ANCA vasculitis. And all of these patients got steroids. And apart from standard of care therapy and steroids, they divided these between placebo, a lower dose of avacopan, and higher dose of avacopan. And more patients in the avacopan group actually had a renal response. They did much better. I'm going to spend more time on the Advocate than this. This was the big trial that came out in NEJM in 2021. This was a group where you had 166 patients who were getting avacopan, 30 milligrams twice a day, and 165 patients who got prednisone taper only. And then both of these groups got either rituximab or cyclophosphamide based on what was needed locally on the investigators' side. IV steroids, so IV methylprednisolone was actually allowed in both groups, and additional glucocorticoids could also be given in both groups. These are important points. Just because somebody got avacopan does not mean that they did not get steroids, okay? All it means is a avacopan group had less amount of steroids than the prednisone group. So if you look at the mean, prednisone group got 3.8 grams, but the avacopan group also got 1.6 grams as a mean amount of glucocorticoids. So still a decent amount of glucocorticoids, but definitely less than the prednisone group. And they realized, and in the study, is that avacopan was non-inferior at the 26-week mark. So half a year, avacopan was similar to steroids. And at the week 52 mark, it was actually superior. It was actually better than the steroids. And the side effects between both the groups were completely similar. So one, we talked about cutting down the dose of steroids by itself, but also Avacopan can help you get off steroids much more quickly, and you may use less steroids. You could be sparing. The last point I want to make is something that people actually forget. People always talk about Avacopan. They always talk about reduced dose steroids and Pexavas, but people forget combination cytoxin and rituximab therapies and how that can help you get off steroids quickly as well. This was a trial on the left side where you had 129 retrospective trial with 129 patients, and they got oral cyclophosphamide and rituximab with or without pheresis. And in these patients at 8-month mark, remember, this is the time when people were getting up to a year's worth of steroids. So at the 8-month mark, the median glucocorticoid dose was 0, right? Another trial here on the right side, you actually had a combination of Ritux and cytoxin, sort of similar to the rituximab trial, but not quite, but sort of similar. And they did get Plex. And what they realized was the cumulative glucocorticoid dose, the median dose was 2.6 grams. This was less than, if you look at the Pexavas trial in the prednisone group, remember the prednisone group got 3.8 grams of prednisone as compared to the, sorry, not the Pexavas, but the Advocate trial, the prednisone group got 3.8 grams of prednisone, which is still less than this one. So if you use combination therapy, you can actually use less glucocorticoids. In our own institution, we've been using very little glucocorticoids and steroids in our patients. And I think some of the reason is that we actually combine therapy. We use Rituxan cyclophosphamide quite often, which is now the new 2024 KDIGO guidelines are also recommending. So the take-home points would be that, it's important to consider steroid-sparing therapies for your patients. Reduced doses equally effective and may actually cause less infections and less long-term side effects. Avacopan, which is a C5a receptor inhibitor, can be used in patients who are unable to tolerate steroids. And then combination therapy may help you taper faster as well. And then one last plug, KDIGO actually has a couple of webinars that are coming up, that are out there as well. And Dr. Geeta, who's on our panel, will also be speaking in one of those webinars. So thank you so much, everybody. I'm going to stop sharing.
Yeah, thank you. Thank you, Koel, for excellent overview and talking plaques and Avacopan. So starting the panel discussion. So Dr. Geeta and Dr. Aman. So I would like to ask Dr. Geeta first that what is your means practical clinically? Because if you see on the one hand, there is a large trial, randomized controlled trial, which really does not show any benefit of plaques versus no plaques. And then there are some meta-analysis or the retrospective studies. What is your clinical practice? So Dr. Geeta and Aman, both, I would like to ask these questions. Are there any specific indications and how do you use this therapy?
So thank you, Koel, and thank you, Dr. Bansal. It was great presentation. So from my perspective, I think an individualized approach to using Plex is really required. And I think Koel really went over the limitations of the Pexavas study, especially for us as nephrologists. I think kidney biopsy not only has diagnostic value, but as important prognostic information. And I think looking at the creatinine trend is the other most important part, which was missing, right, in the Pexavas trial. So if I have a patient who clinically has rapidly rising creatinine and a biopsy that shows active disease without much chronicity and a creatinine that is at high, it's not at 1.2, but significantly higher, then that's the patient that I would offer Plex. So, Plex is still part of the treatment for me, but I think it has to be individualized depending on the creatinine trend, the need for dialysis, and the findings on histology. And similarly, in alveolar hemorrhage, I think it's important to know that the mortality in these patients is really high, up to 75%. So even though the EULAR guidelines say no Plex in alveolar hemorrhage, KDIGO says consider Plex in alveolar hemorrhage. But I think if you have a patient in front of you who you think is going to die, and that's the last one to offer, then I would be offering Plex in those patients as well.
Yeah. Thank you, Dr. Geeta. Yes, Aman, what would be, because you would be seeing more of pulmonary hemorrhage than the renal failure patient. So,
thank you, Dr. Bansal, and thank you, Koel, for having me here and the ISN and International Society of Glomerulonephritis. So, actually, my practice is that in line with what Dr. Geeta said, if there is rapidly rising creatinine or if there is a crescentic or focal histopathology on as per the burden classification system, we'll surely go ahead for plex in patients with renal failure, and of course also with the overlap with the anti-GBM disease. But I won't really be very, be using plex in patients with diffuse alveolar hemorrhage. And my impression is based not only upon the PEXIVAS trial, but if you look at the older studies, like there was one study from early PEX group, which also showed plex versus no plex doesn't really help in diffuse alveolar hemorrhage, although there were some studies which did show some benefit. And the risk of infection obviously always is there. So, and if I bring in the Indian Rheumatology Association guidelines, which have been submitted for publication, the data-driven guidelines, the official position of IRA in those guidelines is that we would be using it in the patients with renal failure or overlap with anti-GBM disease, but not in the patients with diffuse alveolar hemorrhage unless we get more evidence supporting use of plex in DAH. So that's where we are.
So I think so. So there's some difference. So we as a nephrologist, as Dr. Geeta mentioned, if there's a pulmonary hemorrhage in our patient, we go for plex mostly. Maybe not in the cases. See, many patients who come with a creatinine of 6 or 7, they would usually have some chronicity in their biopsy, some fibrosis, some sclerosis. And the patient who is coming early may not have the chronicity, but then this creatinine is less than 4 or 3, and I think there's still a lot of debate. Anybody else would like to comment?
Bansal, if I may dare to speak in front of the galaxy of nephrologists, actually, I would say that it may rather not be all the time. I mean, based upon whatever evidence we have, I think we've done biopsy in fairly good number of patients, thanks to our very helpful nephrology colleagues in PGI. I think we've seen creatinine of 7, 8, 9, 10, 11 also, but not showing a lot of chronicity. So there I probably might not really, because, and that is where the whole game lies. And probably that's why we are more confident as a rheumatologist to use plex probably in that scenario. I mean, probably I'll ask Dr. Tamra to share that data, but I would say it is not always that high creatinine may be equivalent to.
No, it's not always. We are discussing individual scenario is very important.
Yes,
I definitely see that sort of scenario. And the treatment as such, if you have combined disease or the ANCA-associated disease, the patients are more likely to respond to immunosuppressive or whatever therapy you give. In anti-GBM, even if the patient is on the high creatinine, you would not maybe dialysis department, you very little chances he comes out of the dialysis or the treatment. So I think the debate will go on. We should go on to the next important thing, which is the indication of the combined cyclophosphamide and rituximab. See, there is some data from the rituximab trial where they use this combination therapy, and some of the retrospective data have shown. But I want to ask, practically means in all the severe disease. Severe disease means if you have creatinine of more than 4 or 5, what is the standard of practice? Koel and Geeta, what do you mean? You do give combined therapy. Personally speaking, we do not usually give, but then I like to ask, because that is the thing where the people would be interested. Should we give the combined therapy in these severe patient? And then you are talking about plex also, how much immunosuppression? And India, see, a lot of infection, a lot of other issues, but everywhere it is there, but India it is more as compared to US, if you talk about immunity, hygienes, and other things. And most of the patient with vasculitis, they die of infections. They die of infection. So what is your comment on that, Koel?
Thank you so much. I will say that one thing that I didn't mention is when we combine, we actually don't go by 6 doses of cyclophosphamide. These patients are very closely followed by us. And so if somebody is in the hospital, let's say they even got pheresis, they got a dose of cyclophosphamide, and then they got a dose of rituximab. Even though they got both, remember, rituximab peak effect takes about 2 to 3 months, right? So the peak effect is not happening at the moment you're giving it to them. Some effect is there, but not peak effect. And cytoxin effect happens a lot sooner than rituximab effect. My patients with cyclophosphamide retux, some of them have gotten only 1 dose of cyclophosphamide. and a dose of rituximab. Some of them have gotten 2 doses of cyclophosphamide, 3 doses of cyclophosphamide, and a dose of rituximab. So although the RituxFast trial had like the 6 doses, because you have to standardize, right? For these clinical trials, you have to standardize and you give a certain number of cytoxins and a certain number of rituxes. When we follow these patients really closely on like even before they get the infusions, actually we see them almost every month or even sooner before they get any infusion, and then determine whether they need the next one. So we just don't write infusion and they're just going to keep getting it for the 6 months. They'll actually get it individualized on the basis of, hey, are you tolerating it? Do you have an infection? Are you at high risk or not? You know, can I stop it earlier? So we actually stop it earlier, and that's what, and we also get them off steroids earlier. So remember, we're cutting down the steroids here. We've cut down the number of cytoxin infusions. I can't remember the last time any of my patients has gotten 6 doses of cyclophosphamide, even with combination or not combination therapy, to be honest.
So basically you just for the initial 2 or 3 doses and then continue with Ritux. That is what is your standard practice. Dr. Geeta, what is your take?
Thank you. Thank you again. I think my the summary will be the same, but I use the combination therapy a little bit differently. So patients who have severe disease at presentation, which essentially is patients who are requiring dialysis, right? So they get started on oral cyclophosphamide. We don't use as much IV. We use oral cyclophosphamide, 1 milligram per kilo or 0.8 milligram per kilo. Most of the patients require it for about 6 to 8 weeks in my experience. So as soon as I see parameters improving, you know, creatinine improving or the proteinuria and hematuria coming down, then I would stop the cyclophosphamide and give them an induction course of rituximab. So I call it a sequential therapy, not as combination therapy. And the same way with steroids, I no longer use 1,000 milligram bolus. We have learned, you know, over the decades, 1,000 is not needed. So I use 250 milligrams a day for 3 days and then rapidly wean them off the steroids. And they have done really remarkably well. And we have been able to lower both the steroid exposure and the cyclophosphamide exposure.
Yeah, thank you for that. So
Shyam, actually, that question was also in the chat. So just to this question, if you can just comment, both Aman and you, on the max steroid dose you give in the IV form in the initial.
Yeah, I mean, see, the problem with giving pulse steroids is there is no evidence, right? So everything is, it's just like alveolar hemorrhage, somebody's on mechanical ventilator, right? There's no evidence we're going to plex. So here, you know, we have to rapidly, you know, stop the inflammation. So giving pulse method prednisolone makes sense, but I don't think 1,000 milligram is needed. So 250 milligram is what I use. There's one observational study which compared patients who got pulse steroids with someone with the cohort which did not get pulse steroids, and they showed that the outcomes of remission and relapse were not different, but on the other hand, new onset diabetes and infections were much higher in those that got pulse steroids. So I think the lower you use, I think it's going to be better. 250 milligrams seems to have done fine for our patients, so that's what I stick to. Yeah.
And then
so Aman, yes, your comments.
Yeah, I think a couple of questions. First, regarding the combination therapy, I would say we still stick to the either rituximab or cyclophosphamide versus the rituximab rather than combination. And there is data also from Mark Little's group from Dublin, which shows that 1/3 of the mortality in the first year is because of infection. We've used it in between, but I think we burnt our fingers. We had adverse outcomes and more of infections, recalcitrant, unresponsive infections. So we've gone back to our strategy of using only single drug after having burnt our fingers. And it's going, if you look at epidemiologically, our paper is there, which showed that, and there is data from Dr. Ashok Kumar also in Delhi, that the renal involvement as such, as compared to the Western cohorts, is relatively less severe, more amenable to treatment, although it is a rheumatologist's bias there, but it was definitely difference, not only our institute, but from, I'm sure you know, Dr. Ashok Kumar's published data. So we are kind of scary. We use it when there is a refractory disease or relapsing disease. Regarding steroids, we are using less and less of pulses now, same in line with what Dr. Geeta was saying. And we are using the Pexivas rapid taper off. We are also using the low VAS 0.5 milligrams now more and more in people who have relatively kind of milder disease. We start off with 0.5 milligrams, those who are not dialysis dependent, not advanced renal failure, not lung hemorrhage. There we are even using lower doses based upon the low VAS data.
Yeah, thank you, Aman. So this thing. So can you combine this plex with pulse steroid also? So that
Well,
is
yes,
the trial says either plex or the pulse steroid. So do you combine
that was
them?
MEPAX, but I think in real life clinical practice, you do actually. And when there
Okay,
is house
okay.
on fire, you throw the book at the patient.
Yeah, any particular subgroup of patients. So like in renal failure, if the patient is RPGN and we are using either cyclophosphamide as a nephrologist, most of them would use as an induction and then maybe rituximab combination. Or so is there any particular subgroup of patients who present with RPGN and they have a creatinine of 4, 5? Would you only use rituximab, leaving alone? So this is question from Koel and Dr. Geeta. Only rituximab in certain group of patients?
I will say the only people who've gotten rituximab from our side wouldn't be like somebody with a creatinine that high. It would be like more ENT limited, PR3, vasculitis, where we've had data that suggests that rituximab actually works better for patients with PR3 ANCA vasculitis, works better with ENT disease. But if you do have like that higher creatinine that's going up acutely, again, how do we quickly get this under control? Cytoxin, even if one dose, it doesn't have to be 2 or 3 doses. It can be just one dose, and then we can give another dose of rituximab as needed, and then closely follow and see how much you do. So yeah, Ritux only for renal failure of that nature, I probably wouldn't use.
Geeta, yes.
So I think we actually published very early on a case series of patients with severe disease where we only used rituximab, not cyclophosphamide, for induction therapy. And those were the patients who had real contraindications for cyclophosphamide use. For example, bone marrow suppression, history of cancer, and they actually did fine, So when I go and, talk and say I use combination therapy, everybody questions, you're the one who published, this case series of using rituximab and say it works. Yes, it is a small number, but when you're running out of options and you want to do the best for the patient, I think then you really have to choose what works for the patient the best in that situation. And I think rituximab certainly can be a choice in patients in whom you cannot use cyclophosphamide.
Yeah, so probably in elderly or patients whom you think the chances of infections are more, you can probably go with rituximab alone and then not exposing the patient with IgAN. So moving on to the next question, which is there. See, I've seen some of our patients. So there is no standard actually guidelines which say that you should prophylaxis for the CMV. So we usually use the prophylaxis for PCP, and which is after endoxon, and we are using not triple immunosuppression, double immunosuppression only. But I've seen 2 or 3 patients who developed severe CMV disease, and one of them died, another one survived. But what is the current consensus or current understanding whether we should use in CMV prophylaxis in patients whom with treating for ANCA vasculitis? Yeah. Koel, Aman, yeah.
So you do see CMV, obviously you can see CMV that's published and you can see it, but we haven't as a practice used Valsite. I don't know that we have great data to suggest we should or should not, but we do see it. So it makes sense that especially who's getting everything, right? Like that person who got the book thrown at them, right? Maybe they would benefit from it. Have we done it? We haven't, to be honest.
Yeah, Aman, your
Same here. Actually, fortunately, I only remember one patient out of say 500 for 500 where there was a problem with CMV. So fortunately, haven't seen it, or I'm not sure. So, but since you brought this in discussion, maybe we'll keep that in mind. And if other people have seen it, for sure, it's more of a problem in SLE actually, in clinical practice. But fortunately, we haven't had it in ANCA. It's surely been seen in SLE practice for sure.
Yeah, Dr. Geeta, what is your comment on that?
I agree with both Koel and Aman. We haven't really seen CMV, and even the literature, there is really not a whole lot published on CMV, infections in ANCA vasculitis patients, or the role of prophylaxis. And the guidelines don't even discuss, at least for PJP, there's a little paragraph, even though there's no recommendation about PJP prophylaxis, really nothing about CMV. So we don't routinely use CMV prophylaxis.
Okay. So there's so most people will not use, and I think unless there's a more data about it, and we can't really recommend that as a therapy or the prophylaxis. So,
Shyam,
yeah,
I had a question to the panel.
okay. So,
So
no,
I mean, before the CMV,
yeah.
I would PCP, I would prophylax. That's what we normally do.
Yeah,
In the
so
US, we see a lot of PCP pneumonia. But I had a question, like I think the single agent, giving single agent and not giving double agent, I feel like we are then having a relapse rate, and the net immunosuppression of the patient for life just keeps increasing. Why not give them upfront good therapy that consolidates and treats the disease, gets rid of it, so your net immunosuppression over lifetime goes down, prevents cancer, infections, immunoglobulin deficiencies? I'm just, putting it out there. I feel like post-transplant, we do it all the time. We throw the kitchen sink at them, but then pre-transplant, we try to go this one single approach. Oh, one drug, let's try this, let's try that. Why not multi-prong approach? So I just wanted to put it out there, your thoughts on that, Koil, Geeta, and Aman.
I mean, I'm all for it. Like I said, we do use combination therapy, and we're just sparing in the amount, right? So for the steroids, like Geeta mentioned, we also do 250 to 500 milligrams. 500 is a maximum that we would do. I've never done a gram ever. And even then, like the IV steroids pulse, for example, I might do it for a couple of days. I may not even do 3 days, right? If you're giving 500 for 2 days, that's 1,000. So there's a lot of variations there. We also whether we might flex the patient or not depends on the histology and all of those factors. But other than that, we do use a combination therapy a lot more for especially our sicker patients, right? If somebody came in with just like a nosebleed, no, of course not, right? I'm talking about these sicker patients. We do use combination, but then you have to be sparing, right? You can't just. I feel like we put regimens on and then we just forget about it because we've done our job. I think these are the patients who need close follow-up to figure out, when do you stop? Can you stop earlier? And that's when you can actually be sparing with treatment.
Yeah, so there is a couple of questions I would take. So one is the starting dose of induction. So I think that's standard most would use according to the guidelines. And ANCA negative vasculitis, would you treat the same way? Means that's, I think, does not changes. What is your take? Well, Dr. Geeta, ANCA negative?
So, I mean, as most people know, the trials actually excluded ANCA-negative patients for the most part. So all the data is based on retrospective studies, observational studies, and we use the same immunosuppression, and the response rate seems to be the same, except to say, ANCA-negative patients more often present with renal limited disease, more often present late. So their outcomes are not as good as the ANCA-positive patients, at least the renal outcomes. Now, I think, Aman, you may have a different opinion about the non-renal.
No, actually, our own data published as is there that ANCA negativity has a poorer outcome for the same reason. Actually, it's more of a kidney disease, more of a renal limited disease. They present late, more of probably a chronicity already set in. So our experience is still the same. It's published. ANCA negative patients do poorly as compared to ANCA positive.
Yeah, so thank you. So coming to that, the ANCA titer. Now, this is again there's a lot of controversy. So do you follow ANCA titers? If there's a rise in titers, then how you means what? You do the kidney biopsy to see the status, or you just increase immunosuppression, or you just don't care about the ANCA? And this is also a second part, is that if the patient is suppose end-stage kidney disease, and he's going for transplant, ANCA is still higher, would you wait for transplant, or would you like to see that this patient achieve the level below and then we go for transplant? Yeah, that'll be that. Yeah.
There are two reasons that I monitor ANCA. First of all, when you monitor ANCA during induction treatment, and when they become ANCA negative and you have achieved clinical remission, the chances of relapse are much lower compared to those who remain ANCA positive. And secondly, when I'm using rituximab for maintenance therapy, I do monitor ANCA and CD19, just to, not only to know their kinetics, but down the road, I actually use it to guide treatment, because not one size would fit all. Some patients would require every 6 months for 1 or 2 years and then nothing. And then some patients would require every 6 months for 3 years and nothing. And some patients would require lifelong. So we just don't know. So I do monitor CD19 and ANCA when I'm doing rituximab for maintenance. So those are the areas where I would monitor, but would I change treatment just based on an ANCA titer? No, not really. The entire clinical picture needs to be taken into consideration. And your third question about transplant, being ANCA positive is really not a contraindication, unlike anti-GBM disease, to proceeding with transplant. I think it's okay to go ahead with transplant if clinical remission has been there for at least 6 months.
Okay, so you will wait for 6 months, even if the ANCA titers are high, you will not wait and you will just go ahead for
Yes.
transplant. Would you like to give a prophylactic rituximab before? Just if the ANCA titers are high. No, this is just question came out of my mind.
No, I have not really done that. I mean, I've had patients transplant with a titer of 200. They've done well with the post-transplant immunosuppression that we are giving. I have done that for anti-GBM disease to get them anti-GBM negative, but not with ANCA.
And then
Okay,
can
so
I just add one other thing to what
yes.
Geeta said? I agree with all of that. The other thing, and I'm sure she does it just to remind people, is keep an eye on the urine sediment. You know, we evaluate all the urine sediments under the microscope. Sometimes the earliest sign of a disease is not the titer, it's not the creatinine, it is really just the hematuria, the acanthocytes and the dysmorphic hematuria that's going up. And so keeping an eye on the patient and looking at the urine often helps catch it really early. And if you catch it early, it's easy to get into remission and keep them in remission.
Yeah, speaking of which, I think monitoring is really, really important. Renal disease is often silent. So I think during induction therapy, majority of the patients will get, like transplant patients, once a week for the first month, a couple of months, and then at least once a month. And when you're in remission, I think you should still continue to monitor every 2 to 3 months at the minimum. Yeah.
So I think last question, because we are running out of time, that we did not discuss maintenance because time did not permit, but this is would you treat this second drug or vaccine-induced ANCA vasculitis? Would you treat it differently? Does somebody present with RPGN, presenting, and then we had a case where we had this vaccine, Indian vaccine, which was given, and after the second dose, the patient came with RPGN, and this was the ANCA positive vasculitis we treated, and then this patient developed CMV infection. So I would like, so how long is the induction and maintenance different in these patients, or you would just if the patient present with severe renal failure? Oh, Geeta, what is your take?
So I think, for drug-induced or vaccine-induced, the induction treatment will be the same, especially if they have organ involvement. Rituximab or cyclophosphamide based on the severity. But the maintenance, majority of them will not need the maintenance if you stop the offending or the culprit agent. But I have had a minority of patients who have persistently had hematuria. We biopsy them, they're still active disease, so we have given them maintenance treatment. So I don't think everybody will need, but there is a proportion of patients who is going to need maintenance treatment.
I think Dr. Aman has published something on this vaccine-induced
with my colleague, Dr. Raja, actually, we saw a patient. Actually, I agree entirely 100% with what Dr. Geeta has said. So milder for the milder version, obviously may not require treatment, take off the offending drug. But for severe, I think the treatment lines have to be the same, like you will treat a bad ANCA vasculitis.
Thank you, Koel. So any comments from your side? Then we will close it.
I just want to say, like, I've seen a variety of presentations, right? Like you can have just skin limited with vaccine. Hey, 2 weeks later after this vaccine, I now have this palpable purpura. We've seen that, and it's resolved within a few days for a patient. It's gotten better with just a short course of steroids in a patient as well. And then we've had patients where I can imagine they have an RPGN. We've had more of that with like COVID than the vaccine for it. Although I've seen like the earlier stages of the disease with the vaccine as well. But I agree with both what Aman and Geeta have said, right? Like you would treat them initially similarly, because if it's a severe presentation, right? You don't have time. You don't have time to think. And as Dr. Jeanette says, in kidney disease, the sclerosis already starts within 3 weeks. So we've actually seen it in our mouse models. You don't have to wait too long. And that's part of the reason why you want to get immunosuppression started sooner rather than later, because the sclerosis are already set in otherwise. You've lost time. And then maintenance may be not needed because they are off the vaccine, hopefully.
Yeah, thank you. Thank you very much for all the panelists for a great discussion. And if there are some questions in the chat box, the panelists can take them, and we have discussed most of them. Now I hand over to Kenna for moderating the next session for C3GN. Yes.
Thank you, Shyam, Koil, everybody in that panel. It was a great discussion. We're going to move on to C3 Glomerulopathy and the word of compliment. Our speaker for that is going to be Dr. Carla Nestor, who is Jean Robillard Professor of Pediatrics, the Division Director of Pediatric Nephrology. She really doesn't need much of an introduction. She's a pioneer in complement-mediated renal disease and in Iowa City. She's an NIH-funded complement scientist and a rare renal disease clinical trialist. Our panelists are going to be Dr. Bansal, and he was already introduced, and Dr. Purva Sharma, who is one of my colleagues and assistant professor here at Northwell and co-director of the GN Center. She has expertise in ANCA Vasculitis and complement-mediated renal disease. She trained under Dr. Geeta at Johns Hopkins as the co-host of the monthly GN chat that we run. So without further ado, we'll have Dr. Nestor take the stage, and Dr. Sharma and Dr. Bansal will be the panelists.
So can you hear me now?
Yes.
Okay,
Good.
so thank you everyone for joining us today. And I'm presenting a topic that's even more rare than some of the items that you've already heard about. So I'm hoping that I can give you something that is of interest to you. We're going to be talking about C3 glomerulopathy, and we're going to try to address some of the most important questions that are starting to come up in this disease as we move forward in some of our newer advantages to hearing about this disease. I do have a number of potential conflicts. We do almost every single complement inhibitor drug that's been out there. We've been the trial group on that. So I share with you so you can understand what my background is. What I'm really going to talk about is what I think are some key aspects of understanding what this disease is and what we're going to do with it. And so I want to talk very briefly about the natural history. I want to talk about the diagnostic approach. Of course, we need to talk about the complement biomarkers, which is still quite an undone area in our setting. And then we'll talk about reviewing the guideline-based cares, and then finally about the targeted therapeutics, because somewhat like IgA, for the first time since I've been in practice, we actually have what I would consider to be targeted therapeutics for this disease. I'm going to hang this on the case, and I'm going to just briefly ask my panelists a few questions along the way. We will try to leave time at the very end for some discussions for other cases, but this is a 33-year-old female. She presents with nephrotic range proteinuria. It happens to be somewhere around 4.8, for instance. She has hematuria, lower extremity edema, and her creatinine is 1.6. Her biopsy shows us C3 dominant glomerulonephritis, and at the time of presentation, she already has 30% interstitial fibrosis and tubular atrophy. Diagnosis of C3 dominant glomerulonephritis, very easy to make as far as I am concerned, as far as most of your pathologists will be concerned. But what are some of the first things you want to know before you launch on management? Would one of my panelists like to start out?
Sure, I can jump in. So I think the first thing I want to know is whether there was a recent infection in the last, I would say, 3 months, because I mean, that is the most common immune complex or immune infection-related GN, or post-infectious GN is one of the most common cases that can be confused with a C3GN. And I think you want to make sure, in complement activation, we know happens in infection-related GN. So I feel like, the timing of the biopsy, as as opposed to the, if the biopsy is done soon after the infection, or it's done, 3 months after the infection, I think that's an important question that I would want to ask. Of course, infection-related GN has, you would see a classic complement pathway activation, and this is alternative complement pathway activation. And I would imagine that both of them can jump from one to the other. So I feel like that would be the most important question I would like to ask.
That's excellent. And that's exactly the direction you need to go. And you've actually reminded me, I need to talk a little bit about the difference between the classical pathway and the alternative pathway in this setting. So before we start, what I want to really do very quickly is go through some of the nomenclature, because it actually can be confusing. So the first thing is C3 glomerulopathy is in fact C3 dominant glomerulonephritis, but particularly we think that it is specifically related to complement dysregulation, not the complement activity that Purva was just talking about very briefly with respect to post-infectious glomerulonephritis. So the distinction I want to make for you is C3 glomerulopathy equals the disease of complement dysregulation versus C3 dominant glomerulonephritis is a histology term. It's like FSGS, right? It's a histology term of what you see on the biopsy, but it does not exactly tell you what the patient's clinical story is. Unfortunately, as was already indicated, it applies to other diseases other than C3G. For instance, it was brought up that post-infectious GN will be classical pathway. Actually, it is in 70% of the time. But there are about 30% of post-infectious glomerulonephritis patients that actually have C3 dominant glomerulonephritis on the biopsy. And then if it's not complicated enough, C3 glomerulopathy, C3 dominant glomerulonephritis. Now we threw in C3 glomerulonephritis is the second flavor, if you will, of C3G. There's dense deposit disease and C3 glomerulonephritis. And I know they're very similar terms, but it's very important because you need to make sure you're dealing with the correct disease when you're thinking about whether you've had response, no response, whether you should try a particular agent. So very briefly, what's the presentation? It does not have to be isolated deposits like we thought back in 2007, 2008. The light microscopy pattern also doesn't have to be membranoproliferative glomerulonephritis, which is what we knew DDD by for the longest time. Type 2 MPGN, it can be mesangial proliferation. It does not have to have the split basement membranes. Then this is really the point that Purva brought up. We have to rule out an infection. And this is a guideline-based therapy or an guideline-based decision that you're going to be making, or a definitional decision you're going to be making. Exactly what it stated, the biopsy has to be taken 12 weeks after the infection in order for you to confirm that, at least by guideline, that it is C3G. Now, you could at 10 weeks have an incredibly aggressive glomerulonephritis, and that's going to make you feel like that's truly C3G. Whereas by 10 weeks, honestly, your PIGN should be improving, your C3 should be improving. If it's classic PIGN, the bottom line is, keep in mind that if you take that biopsy immediately on presentation, I'm going to say, I'm not sure what you have yet until I see more of that patient and what happens with their natural history. The real point, if it's post-infectious GN, particularly in children, but also in adults, it's believed to be a more benign disease. It's believed to be more transient. This is normal complement response to an infection. And we believe once the infection runs its course, the kidney can get a chance to recover. It will go away. Not always, I will admit freely, especially in adults. And then another important piece, I think, is, and this gets to the classical pathway, alternative pathway problem, classical pathway can, in fact, trigger C3G. And in fact, your first biopsy on your C3G patient may be an immune complex GN. And that's kind of important because when you biopsy them again, they're C3G, you should just call them a C3G. This was reported to be in about 8% in the Columbia cases, but we've seen it in up to 12% of our cases. So you can see that there's some variability here in understanding this biopsy diagnosis before you can really understand clinically what you're dealing with. Then there's this, which we do not know the answer of how we're going to actually solve this, but C3 deposition may occur in end-stage kidney disease in a lot of settings. And it doesn't even have to be at end stage, but there may be intrinsic activation at the level of the kidney when factor D, one of the major, the rate limiting step complement protein, if you will, in the alternative pathway, the kidney tubules are supposed to excrete it so that as your patient progresses to end stage, factor D goes up. it is possible that at the end-stage kidney disease stage or near end-stage kidney disease stage, the complement activity at the kidney is not primary complement problem, but it is an effect of end-stage kidney disease. We don't know this for a fact, but we are again seeing many, many near end-stage kidney disease biopsies with C3 deposition. So keep that in mind. And then I just pulled up 2 other publications. There has been C3 deposition noted in diabetic kidney disease, where we can all reasonably agree that diabetic kidney disease is not a primary complement problem, yet C3 is often deposited. And then also in FSGS, C3 is often deposited. So again, what you're hearing me say that it can sometimes in some patients be very difficult to actually understand what their disease is. Is it complement dysregulation as primary, or is this a secondary event based on any number of things? So, and then I can't help, because this is very important, and this was published in the recent KDIGO. If your patient presents for the first time with C3G over the age of 50, please remember to rule out paraproteins. And, this is not the multiple myeloma patient. This is the MGERS patient. This is a patient who has C3 dominant glomerulonephritis because of their paraprotein. We don't know exactly what these proteins are doing. Seppo Mary has published, other groups have published that they may have nephritic factor-like function or factor H autoantibody-like function. But the bottom line is they do dysregulate complement. They do cause a C3 glomerulonephritis. The range of presentation for these group is anywhere from 33 to 83% in your 50-year-olds. So that's why it's very hard to tie down exactly who this is going to affect. But the reason to focus on this is that it appears that based on at least these limited publications that, and again, these are not clinical trials, but they're either retrospective or cohort studies, that if you treat the clone, you may actually do a great service, if you will, to treating the C3 glomerulonephritis. And that's why it would be important to single these individuals out. Such that, as I mentioned, the 2021 KDIGO guideline said, older than the age of 50, first C3G episode, please rule out paraprotein. I will tell you the youngest paraprotein related C3G I've seen is at the age of 17. So it's not just the 50-year-olds, but if you're doing this economically, that would be the group that you would be thinking about. So how about the burden of disease? Well, C3G is generally a chronic, persistent activation of the complement system, not the acute, transient activation that you would see in post-infectious. End-stage kidney disease in up to 80% of children by 10 years and 30 to 50% of adults by 10 years. Unfortunately, histologic evidence of C3 deposition, not necessarily proliferation yet, but C3 deposition occurs almost immediately in most patients. Then you can have recurrent clinical disease in up to 50% of patients by 10 years. So the burden of disease is actually quite high. If I give you that 33-year-old with nephrotic range proteinuria and a creatinine that's elevated, 1.6, what other assays might you want? And I'm going to go back to my panelists.
Carla, before you go to the panelists, one of the questions that came up while you were talking about the paraproteins was, if the paraprotein acts like anti-factor H, is there a role for Plex?
Absolutely. That's an excellent question. And the assumption would be that yes, if you were plasma exchange this patient, you would be able to remove the factor H. There's limited published data. There's at least one trial, I think Brad Roven actually put out there, that said that in some diseases, you can remove enough factor H to actually bring remission. Here's the problem. Can you continue the Plex long enough to keep the remission? So I would say that I have a soft maybe about whether this would be useful. So I think at the end of the day, you're going to have to get rid of the protein, or you're going to have to get rid of the cell that's making the protein. So you'll have to keep that in mind, but it's not unreasonable in the acute setting to consider that. I'm just not sure you're going to be able to maintain it. Would you do genetics, my team members?
Yes. So the short answer is yes. I think in all patients of mine who have a C3GN diagnosis, I would send for genetic studies, knowing that a lot of this might not be genetic, and it would be, mediated by, C3 nephritic factor or C5 nephritic factor, or something that we can't detect. But I think the genetic studies help me, if they're positive, they would absolutely help me decide the course of action, how long to treat this patient, and potentially how this patient is going to behave. So potentially, I know that whether it's the terminal complement pathway that's activated, it's the upstream effects or the downstream effects. Is the MAC activated, or other factors, including other complement factors that are upstream activated? So it gives me sort of like if it's positive, it will give me a sort of a physiologic description of what's going on with the patient. Of course, factor H, as you said, mediated autoantibodies. You might go towards a different kind of treatment, for example, plasmapheresis. So I think acknowledging that this might be negative. To be honest, most of my patients that have had genetic testing on have all been negative. So, but have I not, have I done it in all patients? Yes, I have. So I think I would, but acknowledging that it might be negative, but will help me if it's positive.
Yeah, go ahead. Sherman, I wasn't sure if you wanted to say something.
Yeah, so I agree with Purva, and obviously you would like to do genetic testing in most of patients who you are suspecting C3GN. But in India, if you talk about genetic studies, these are not so commonly available and costly. Now we do in our patients. I work in a corporate hospital where patients can afford most of these things, but sometimes the interpretation of these genetic studies is difficult. Means you get a lot of variation in CFHR and all that, and I am not sure what to do with that. Means the variant of uncertain significance sometimes, and then you don't know where you should how you treat and deal with it. So we have some cases I will show you, and then so
Yes,
we will like.
Yes, you
Yeah.
both have brought up excellent points, and I'm going to try to just sort of give you what I think is some of the background for why you may or may not do it. And I'm happy to share what my practice is also. But let's start with part of the reason to consider genetics in this group is that there are actually very good animal models that even tell us what this disease is, frankly. First, there's the Yorkshire pig that had a factor H mutation that actually had C3GN on biopsy. Then there's the most commonly used animal model in our laboratory settings, which is also a factor H knockout that has C3GN on biopsy. But as Purva has already mentioned, in humans, the vast majority of humans are not driven by genetic drivers. So the fact that, and I assumed you were going to tell me that genetics are not always going to be available. And so if you're going to be terribly economic about this, you're going to try to go looking for the autoimmune drivers of disease first before you go to the genetics. But there are times I would agree that I do genetics on for instance, I will do genetics on pre-transplant patients, et cetera, et cetera. But anyway, genetic drivers probably only account for about 21% of the patients. And you're right, it's a smattering of things. Often you're going to get a VUS. You need some help figuring out whether it's functionally significant, et cetera. But in certain patients, it's going to be critical. And if I move forward, though, to think about the autoimmune-driven ones, about 50, depending on which cohort you look at, about 50 to 80% of patients may actually have a C3 nephritic factor. And I'm going to show you where that is in the pathway, and about 50% with C5 nephritic factors. So you can see this list of autoimmune proteins that actually drives this disease. And I would say that even though our animal models are our best support, the complement is involved in this disease. I think that in humans, C3G is not primarily a genetic disorder, just so that you understand that. So I'm going to share with you, and I don't know if my mouse shows up for everyone in the room, but so I'm just going to verbally say, for the alternative, this is a disease of the alternative pathway, essentially. So for the alternative pathway, we're talking about moving from C3 down to MAC, or C5b through 9. Keep in mind that the amplification loop of the alternative pathway as you move to MAC happens to be the amplification loop for the classical pathway and the lectin pathway. That's why it becomes such an interesting target for some of the new therapeutics. Here's the problem. You're going from C3 down to MAC. if you have one of these nephritic factors, either C5 nephritic factor or C3 nephritic factor, or a problem with C3b, or a problem with factor B, et cetera, genetically, then what happens is not only are you making MAC, but you are making lots of complement breakdown products that eventually end up on the kidney. So that's the reason to kind of think about what the pathway looks like. But as is always the question I get, what are the complement biomarkers doing for us in this setting? And I will tell you, I work in a lab where we test 19 different complement biomarkers on our C3G patients. And I will also be completely fair to you that we are not clear whether they give you exact evidence about how to manage the patient. So I thought that the next best thing I could do for you is just tell you what these biomarkers tell us. So first, let's talk about BA and factor D. BA and factor D, interestingly, are just a suggestion that the patient has CKD. And by the way, these are blood biomarkers or serum biomarkers. These are not urine biomarkers. If your BA and factor D are elevated, your patient has significant CKD. BB is elevated along with B is down. C3 is down, so you are consuming products making BB, for instance. These are very clear evidence that you have derangements in the alternative pathway. So those can be very helpful if you're trying to sort out whether your patient actually has an AP abnormality. C4, most of you will know this. We don't do a lot with C4 in our lab, for instance, but it's low in classical pathway diseases. For instance, it's low in lupus, for instance. It's low in cryoglobulinic kidney disease, et cetera. So C4 is one of those parameters that may be useful for you. What about C5 and C5b through 9? You may recall that those are at the very end of the pathway. So in terms of nomenclature, if you have abnormal C5, so low C5, high C5b9, we're talking about terminal pathway abnormalities. So you can see what I'm doing here. I'm trying to separate you out into whether we're talking about primarily an alternative pathway problem or a distal or terminal pathway problem. And then, of course, just to be complete, because most of us can get CH50s, sometimes we can get APFAs, they're really very useful just to telling you whether the pathway is abnormal at any one moment. What I am just recently discovered is they are excellent about helping me figure out whether they are being appropriately blocked. Is the alternative pathway blocked now? I can look at my APFA. Is my classical pathway blocked now? I can look at my CH50, et cetera. So this is my slide to sort of share with you what's going on with the complement system in C3G patients particularly. So if I go to now, let's say you've got that 33-year-old with C3G, and I'm going to tell you it was not just C3 dominant glomerulonephritis. I've declared she's C3G. What would you treat her with, or how would you treat her?
If I get this patient and this C3 glomerulonephritis is the diagnosis, so I would go with the steroids, 0.8 to 1 milligram per kg, and then along with the MMF, would be the initial approach, and then see how this patient behaves, and then gradually taper the steroid over a period of 6 months or so, and then continue MMF for a longer period of time and see how she does.
Perfect. Perfect. I don't know if you want to add anything.
I think I would do the same. I just use a little bit lower dose of steroid, if you will. I think probably around 20 to 40 milligrams a day along with the MMF. I don't necessarily go to 0.8 to 1 gram per kg, but yeah, exactly as Sham said, and I think same
Very
thing.
good. Yeah, and I will say that I do a lot of pediatrics also, so we tend to sort of stop at the 60 milligrams also, just and we also, by the way, tend to wean off a lot sooner than I think a lot of our other glomerular disease groups do. But yes, both of you are 100% correct, and I will say that, and I'm sure you guys have potentially been frustrated by this, but this is not based on trial data, right? This is really based on retrospective data. This is based on what seemed to work in another one of our glomerular diseases, right? But nonetheless, it was all we had when we were developing the KDIGO. And so it ends up that you start with supportive cares, which you are already at with most of these patients. You're on the ACE inhibitors, the ARBs, maybe these days even SGLT2 inhibitors, et cetera. If they still continue to have greater than a gram of urine protein, absolutely, this was what was recommended. You move to the steroids and the mycophenolate, whichever your local dose is, and you're allowed to choose, frankly, because again, there's no clinical trials. And then again, if you start, you're going to use the mycophenolate mofetil and the steroids. So the sad truth of it is, though, that even if you take the caveats, is that the doses and the durations of treatment with mycophenolate and steroids are quite different across practice, as you two have just actually shared with us is true for you. Also, the time for follow-up is variable. Unfortunately, the response is quite variable, and I really am only presenting to you the six of the retrospective cohorts, but you can see, I happen to highlight in green who responded well. You can see there's actually, frankly, not enough green on this chart for most of us, but also in blue is partial remission. But really what I wanted to point out is that unfortunately in at least one of the groups, there was actually no response to the mycophenolate mofetil and the steroids, but there's plenty of kidney failure that's still going on. One other caveat I will say that it's been reported by the Spanish group, the Glossen group, for instance, that if you have a genetic abnormality, which maybe up to 21% of patients do, they had non-responders in that group. So that's something to remember, but that's exactly where you're going to start for these patients. And I'm hoping that you have access to those agents in most of your communities. So if you're a non-responder, then when do you escalate? How long do you wait? Or, what's your triggers for escalating? Anyone want to share their triggers?
See, in India, this eculizumab, which is the next step, maybe, so that is not freely available. So because of the, so we get some of those in gray market, but then it's not, and it is very costly. So we really, at this point, if the patient is not responding, we might not do. We will just keep the patient on conservative treatment and then see how he does over a period of time. So that's what most of the people in India will do, the nephrologists will do. Yeah.
And for us, I think, so I'm excluding patients who have rapidly progressive disease or crescentic disease. So we're talking about this particular patient who doesn't have crescentic disease. And I think, and I've not had very good luck with MMF and steroids, just anecdotally as well. So I think 3 to 6 months is probably my time limit, more closer to 3 months. If they're not improving, in fact, if they're getting worse at 3 months, I would add something else, which is typically eculizumab. Again, eculizumab doesn't have great response either. But I think if they're getting worse at 3 months, I would add something else, which is typically eculizumab, for lack of a better choice, unless they want to participate in a clinical trial, which we offer them to, but I think it's not as, some patients don't want clinical trials, and there's a lot of barriers to enrollment. And I think, so that's probably my time limit for escalating care. And I think eculizumab is one of them.
Hey,
Yeah,
Carla,
yeah, go ahead.
a related chat question is, when would you do eculizumab up front as opposed to MMF first? Is there any instances where
good
you
question.
just go straight to eculizumab?
Yeah. And unfortunately, it's going to have an economic and a feasibility or efficacy answer to it. And I will say that, again, I practice med peds, and I do have quite significant difficulty actually getting a hold of eculizumab for adult patients. I don't have as much trouble for pediatric patients. That's just must be the difference in our third-party payers. But you might recall my diagram where I said that on your way to get to MAC, you've got this offshoot of deposits being placed on the kidney. So because most C3G has this constant production of breakdown products, and we frankly don't know how much of C3G is based on membrane attack complex. Unlike atypical HUS, we're pretty comfortable. You block membrane attack complex, you're going to get control of the disease. We don't know with C3G how much of it is MAC based. We actually don't. So that is the reason why I won't go to eculizumab first. Economics, and because I'm not sure it's the right drug.
Sorry, go ahead, Carla.
No, I was just going to say, I have patients that have responded to eculizumab, but a lot like what was said earlier about MMF, I have lots of failures on MMF, and I have considerable failures on eculizumab. So go ahead.
No, I was just going to say that I have tended to use eculizumab in patients with high MAC levels, but it hasn't corresponded to benefit in terms of like, it's not like, if they had high MAC and I gave them eculizumab, they got better. They necessarily got better. So I don't think there's a necessary correlation, even in studies, of using, and it is, which exists in atypical HUS, as you said. I don't think it exists in C3G. So I agree. I would not use eculizumab upfront.
Yeah, so I agree 100%. And I'm going to share with you just one study just to give you as an example, but for some of the reasons that have already been brought up. So the reason to escalate is, and I choose 4 to 6 months just because, probably based on another glomerular disease, but it was suggested 3 months, that's fine too. You want to give your patient a chance to respond to mycophenolate because if it works, it's great. It's an oral med, it's cheaper, not a lot of downsides to it. But if you're really having unacceptable need for admission for, diuresis, or the edema is so bad the patient can't, go on, so to speak, you need to consider escalating. And then I think that you're exactly right. Up to this point, in fact, KDIGO said you could consider eculizumab. That was their consider point. But then there's also this idea of clinical trials, which, last year was fantastic. Right now, currently, I don't believe there's any clinical trials anyone can get into for C3G, except for the adolescent group. So the 12 to 18-year-olds right now can still get into clinical trial, but I'm not aware of any phase 2 or phase 3s going on in C3G right now. So we're kind of stuck, at least thinking about eculizumab as an option. And so I'm presenting this one. It actually included 26 patients. I'm only sharing with you the adults. The other half of this group were pediatric patients. So 6 of 26 had complete remission. It's important to note that some of these were on mycophenolate and steroids. And so this is over and above what might be happening with mycophenolate and steroids. 6 had partial remission. And as was already suggested, membrane attack complex elevation did not predict responders in this group. And in the original Columbia group, they did suggest that MAC was what predicted responders, but not in this group. So again, we're sort of sharing with you what the anecdotal experience is. Eculizumab may have some extra effect, but it's still not perfect for us yet. So what if, because patients are already on mycophenolate and maybe low-dose steroids and some calcineurin inhibitor. Incredibly busy slide, so I just mainly give that to you to share. There have been lots of reports to share if you're on mycophenolate and steroids in a much more controlled fashion. I mean, we watch these patients very closely. There's still lots of recurrence going on in that group, and I because it's a busy slide, I'm going to say it's 176 patients. The range of recurrence across all those studies was anywhere from 33% to 84%. So some studies or some centers are not having quite as bad recurrence. Here's also the problem for you. The time to recurrence is 3 days to 101 months. So is that hard to plan for? Yes, it is. So the drivers of disease were not always known. In fact, it was really only known in 2 of these cohorts. And in one of them, they knew that there were pathogenic gene variants in some patients. And in the other study, they knew that there were nephritic factors, so autoimmunity. So you can see, again, these are patients that are already on mycophenolate, already on calcineurin inhibitor, maybe some steroids, and they're still recurring. So this was a meta-analysis that thought about other things. So the question was asked a few moments ago, would you PEX these patients, for instance? Well, let me just share in meta-analysis, which means it's built off of retrospective things, 122 patients. If you used eculizumab, there was still a 33% allograft loss in this group of patients. If you used plasma exchange, there was still a 42% loss of allograft. And finally, if you used rituximab, even though it makes perfect sense to consider that in a nephritic factor-driven disease, B cells making an abnormal cell that you don't like, it was not useful in these groups of cohorts, and you can see from these plots. I just want to share with you what's going on because I'm hoping to push you forward to what might be coming in the Iowa cohort. So for instance, we've transplanted 20 C3G patients and our recurrence rate happens to be a little bit lower. I have no idea why, it's probably a numbers issue, but about 25% of patients recur. So we are working now on trying to figure out who is going to recur. And because the hot question is, what are the biomarkers going to do for me? We're using biomarkers to try to figure out. So we tried to figure out who was going to recur. Based on our algorithm, if you will, we predicted 2 would recur because of pathogenic variants. I think that's what you all are seeing too, that if there is a pathogenic variant, these patients are very frequently going to recur. We also predict that if you've got very high titer nephritic factors at the time of transplant, a little bit different than ANCA, of course. If you've got very high nephritic factors, very active alternative pathway at the time of transplant, that you're going to recur. So we predicted those 4 of those 5. We worried that about 2 because they if you will, had paraproteins, if you will, or they presented later in disease. So we worried that they were also going to recur. We have also predicted that 1 other patient will recur, and we're watching him like a hawk to make sure that we don't lose track of him. But we're trying to figure out if there is lots and lots of activity. Also a very busy slide, but just to say, this is nephritic factor, C3, C3, membrane attack complex, BB, C5 level, and alternative pathway assay, et cetera. A number of different, very active biomarkers at the time of transplant is really what I'm getting to. So this is not only those that we transplanted here, but then we have another 20 that are in our natural history study. So we looked at 40 C3G patients. We had 11 recurrences out of all comers, so in our database, and that we actually transplanted. The pre-transplant excess complement activity, we were able to predict recurrence if we looked at how many and how much of their biomarkers were active. And hopefully this will make some sense to you, but we're just temporarily calling it a pre-transplant recurrence score. But you can see that these were the group of patients that recurred in red, and they're the ones that actually tend to have the higher biomarkers. So it's beginning to sound like we may be able to predict who is going to get recurrence in transplant. And a score of 3 or greater was able to predict 100% of patients for us with 84% specificity. So you'll need to listen for a little bit more on that because that's not published data and it's not peer reviewed, but I'm trying to encourage you to think a little bit more about the biomarkers as potentially offering something to us is really where I'm going with that.
Hey,
And,
Carla,
yeah.
Related to that is a question in the chat. If with these patients, mostly living donors from family, because of if their mutation ran in the family, should we be doing disease donors more in these patients?
Good question. And I think that it's incredibly regional. For instance, there are some countries in the world that won't use a living donor, for instance, for a C3G patient. Here in the US, or here particularly in our practice, we will use a living donor, even related, as long as we understand what the recipient's disease is. For instance, it's genetic negative, then we don't look at the donor's genetics. If the nephritic factors are not present in the donor, et cetera, we will do that little extra workup. But we are willing to use living donors. And the most extravagant, I would say, that we've been is we've actually used one sister to transplant. This was a 40-something-year-old, one sister, 40-something-year-old to transplant a 30-something-year-old sister. That's as close as we've gotten. Generally, we prefer unrelated donors, frankly, because I think there's a lot that we don't understand. But we've not prohibited it technically. We do, as was mentioned earlier, we do, going into transplant, do check the genetics because you don't want to be caught getting an early recurrence in a patient that you didn't bother looking. But I will say that if you're economically strapped, you may need to be in that situation. But that's just our approach is to look at our transplant patients. So going forward, I'm just going to give you 2 slides on, we've already talked about how mycophenolate's not perfect. Well, mycophenolate and steroids is not perfect. We've talked about how eculizumab's not perfect. You know by the burden of disease that what we've done historically is not ideal because these patients were going to end stage really unacceptably high, if you will. It's one of the worst glomerular diseases out there. So I'm going to just talk about 2 agents, and that's because these were peer-reviewed published studies. So first is the C3b inhibitor called pegcetacoplan. And very quickly, it's a sub-Q infusion. And this is clinical trial, by the way, twice weekly, native kidney C3G. Their endpoint was urine protein. They also had secondary endpoints about what happened to the C3 and what happened to the membrane attack complex because of what's been mentioned. You know, are we doing something with the terminal pathway in this setting too? And what they noticed in this relatively small group of patients, obviously, that they had a 50.9% reduction in urine protein and a 666% increase in the C3, which we believe gets to the root of the disease, right? If you can calm the alternative pathway down, maybe these patients do better. And then finally, they did see some improvement in the membrane attack complex. So this is the first good presentation about a alternative pathway blocker that might actually be useful for these patients. But again, it's phase 2. Right now, you're waiting for the phase 3 data. They've already reached their 6-month mark of placebo controlled. So hopefully we'll be hearing more about this. And importantly, it was actually a safe approach. So what about the factor B inhibitor? Also phase 2, where this one is called iptacopan. This was an oral agent that's taken twice a day, native and transplant this setting, so might be important for those of you who have run against those problems, obviously. Endpoints this time, same urine protein to creatinine ratio. This time they used C3 deposit score, though, in their transplant group because they didn't require their transplant group have high-grade proteinuria coming into the study. And so just very quickly, they had a significant change in the urine protein, so a 45% change in the urine protein. And importantly, they saw on the transplant kidneys that they actually had a 2.5 change in the C3 deposition score. So again, if you believe that that's the root of the proliferation in these patients, then that's actually potentially a good finding. That's not a regulatory agency acceptable finding, by the way, but that is something that I, as a scientist in the complement world, would like to see, that the C3 goes away, frankly, on these biopsies. And then, of course, this was a safe study. So similarly to the pegcetacoplan trial, you will see the answers to the phase 3 actually just coming up here very soon. At ERA, you're seeing the phase 3 results, I believe. So now let's very quickly go back to the case summary. We've already talked about the details of her, so let me talk. I did the biomarker panel on her, of course. She has a low C3, very commonly seen in C3 glomerulopathy patients, not always a high BB, so she's breaking down factor B, a low C5, and a high MAC. So as mentioned earlier, this is a group that potentially has a lot of terminal pathway activity on top of their alternative pathway activity. Interestingly, we found that she had a half normal factor H level. And does anybody in the group know what that means to me? So I look at a lot of biomarkers, and whenever I see something exactly half of something, I'm worried that one allele is not working. So in fact, it turned out that she had a pathogenic complement factor H variant, and therefore she cannot control her alternative pathway, and that's why this patient has disease. I had given you the hint that I don't do eculizumab very frequently, but this is the patient I would be interested in doing eculizumab in, for instance, just as an example. And in fact, she's on eculizumab right now. Unfortunately, she is progressing towards end-stage kidney disease, but the slope of her decline has definitely changed. She's not doing quite as bad as she was before adding the eculizumab. I think, obviously I've talked fairly quickly on this, and I recognize that C3G can be a very complicated disease. I would keep the nomenclature in mind, because if you don't respond like you think you should have, it could be that you've got the, I won't say wrong disease, but a different disease than what you think you have. and keep your eye out for what's going on with the biomarkers and when can you actually get your hands on some of these AP blockers, because I personally believe they're going to be a game changer. Thank you.
Thank you, Carla. I think we have some questions in the chat, and then maybe Shyam might have a case he wants to throw at you. But one of the questions that one of the attendees wanted to know is, do you check C3 nephritic factor in all your pre-transplant workups for these patients?
Actually, I do. And again, we owe you a publication on this, let me back up and say, if I know that nephritic factor is driving the disease, or I believe that nephritic factor is driving the disease, you could get away with not doing it immediately pre-transplant because I kind of already know it now. But what we've discovered over the last 3 or 4 years is that the nephritic factors can change a little bit. They can actually get better over time. So if I knew that I had a 4+ nephritic factor on presentation, I might want to know it could be gone. That's unlikely. Or it could be 1+ now. That's the patient that I don't think is as likely to recur. So that's the patient that I'm sort of thinking about the nephritic factors. Again, if you know it's nephritic factor driven, you wouldn't have to, but I think eventually we're going to get a sense about whether these nephritic factors are going to be predicting whether you've got a recurrence. And certainly in our cohort of 20, high-grade nephritic factors was predictive of recurrence. But that, again, we owe you a publication on that.
Carla, jumping on,
Yeah.
can I jump on that question? So if you have a living related donor and the patient has had all genetic workup is negative, including the nephritic factors, do you do this testing in the donor as well?
If the
Routinely?
patient was genetic negative, no, we don't test the donor. We are going back and forth about the nephritic factor testing. And part of that is because HLAs are, obviously passed down and B cells are passed down, et cetera, et cetera. And so there have been people in our group that have suggested that if a patient got their disease or believed to have their disease from high-grade nephritic factor, should you check the donor? I personally don't think that you need to. I think that for instance, you're asking for trouble. If the patient is high-grade nephritic factor but no disease, is that going to help you make a decision? So, it's going to cause a bit of problems, I would say. We're much more sound about the genetics here, frankly.
Shyam, in India, what is the availability of these complement biomarkers?
I was going to ask about this. So see, we do this C3, C4, these are routinely available, but not BB and MAC and these things. So this is very difficult. So I have not done personally, so I don't think they are available. We can get the genetic studies done like complement factor H, I, and other mutation. We can do C3 nephritic factors that we can do, but not some of these BB and MAC. So this is not done. I think some of my colleague, you have worked with Siddharth, so he sometimes send these samples to France, or he has a tie-up there. But routinely, I don't think maybe 1 or 2 institute might be doing, but not in-house. So it's a very limited availability. So it's difficult. And then the second important again is the genetic studies. Because a lot of time, this VUS comes, and then you are not sure what to do about that. And frankly, if the patient does not have DTD, patient just has C3, we unfortunately don't have such a big disease donor program. 85% of the transplant in India are from living donors, and deceased donor in some parts of India, like South, in Tamil Nadu, in Telangana, and in some Gujarat, there are good deceased donor, but most of the India, it's mostly the living donor. So we take living donors in most of these patients also. But obviously, this disease is relatively a new disease. You would say still a lot of things are not clear. The last 10 years or so, 2013, first time it was classified. So we are still learning about it, you can say.
And I can say that it's okay that you don't have the biomarkers just yet because we don't have a direct connection to them to your management. So this is perfectly fine that you don't have them yet. You need to wait until we can get that data out there a little bit better. But I will also go back to something you reminded me that I didn't say. You're exactly right. If you get a VUS, as you guys know, it's very possible that it's benign, right? So you will not want to make big decisions on a VUS. Where it's the most helpful is like in this particular patient, which I obviously picked an obvious one. She had a pathogenic factor H variant, and there are geneticists that can tell you whether something is pathogenic. But if you get a VUS, you're right. You're a little bit stuck about knowing whether you're at high risk for recurrence or not. But I think it's sometimes helpful that if there's no family history in that setting, but even that, as you know, is not perfect because there certainly can be variants that are de novo, if you will, and they're going to be significant enough to cause your patient to recur. But you can only you can't prove that something is not a VUS just yet. So you're doing what you can do.
Yeah.
So in that regards, Shyam, you think it might be more cost effective to get these levels done in India opposed to genetic testing? What do you think might be more effective in India to get some more information to help these patients?
No, so definitely see these levels, if they can tell you more about the activation of the pathway and the alternate pathway, and then it is. But I don't know whether how costly are these, because you do these in your labs and where the most of the these testing are covered. But once you come to the private, in the India, most of these tests, even they are in the private, and the patient has to pay from his pocket unless it is in the institute. But I am not aware that in any institutes in India also it is available. So that's a big question, the cost of these markers, and then obviously the understanding. That's very important, that if you understand these things, that how to interpret the marker, that's also equally important. Once you order everything, and then you have to really know how to use that information.
On the same note, just a question, some of the same factor deficiencies antibodies exist with atypical HUS. Why do some patients, any of you, get C3GN and some get atypical HUS? Can you get both? And what's your experience from three of you?
Yeah, I'll start first. I don't think we know exactly the answer, but I'll give you an example of what we think might be going on. Very frequently, if the patient is going to develop the phenotype of atypical HUS, the genetic variant is in the terminal part of the gene where the protein attaches to the cell surface area. That's the patient that's more likely, if you get your gene variant on this end of the protein or on this end of the gene, that's when you're more likely to get the atypical HUS phenotype. And that's because that's where you're protecting the endothelial level, right? As opposed to if you get your genetic variant on the other end of the gene, that's the part of the gene that binds C3, and you need to bind C3 in order to control C3. So that's why that patient is more likely to get C3G. Now, the truth of the matter is genes are spread out across abnormalities are spread out across the gene, and that's not a perfect connection, but that's kind of the way we think about it. But it does, if your underlying question is, if your phenotype is C3G, you tend to keep C3G as your phenotype. You don't suddenly flip into a TMA phenotype, for instance, typically. So we don't know exactly why that happens. The second assumption that there is that there's something about an individual's endothelium that makes them a little bit more at risk for the TMA phenotype versus not at risk. But those are just assumptions currently, as far as I'm concerned.
So question, can I?
Sean.
Yeah. So this is a question. So one of the cases which actually we are handling, this is a patient who has this presented with nephrotic nephritic picture, and we initially treated with MMF steroid, and for a year or so initially showed some response, and then later on he developed some infection after 1 year. So his proteinuria came down from 6 gram to 500 milligram, but then he developed this infection and we had to stop the immunosuppression over a period of 3 or 4 years. He progressed to end-stage kidney disease and now he's initiated on dialysis. And his biopsy showed DDD. So what about the transplant in this patient? And we had got this genetic studies which have shown CFHR3 mutation, and which is again VUS, and the patient is very keen for transplant, and donor obviously is a living donor in the family. C3 has never gone up beyond 40 even after the treatment, 40, less than 40, 45. So what would be your means whether we should transplant this patient? If we want to transplant this patient, then how I should go about it?
Was one of your VUA, I told you my superstition about half.
Yes. So one of the slide charts I shared with you, this is a complete CFHR3 mutation.
Yes.
Yes. So that is the mutation which, and then in this clinical exome, there was CFI and then C3, and which were again not clear. So, and then we did this MLP and we found this CFHR3 gene mutation. Yeah. So this is the mutation. Yeah, and the next one. So this is one C3. This is and then one CFI mutation, but then there are multiple other mutations which are probably just, and then the next slide. Yeah, so this is the, so how to go about transplant in this patient.
Yeah, so again, of all of the options that you saw there, the most significant one probably is the C3. And again, you're right, it has to remain a VUS, but I mentioned to you, it's entirely possible that's going to be the thing that's going to be a problem. But and I think it's worth saying, for instance, the PKD1, the NRIP1, et cetera, these are not related to C3G. So I would say with respect to transplant in a C3G patient, I would be less worried about them. The factor I mutation, I'm not sure about. Again, obviously it would have to stay a VUS, but let's just say we have to keep everything a VUS. The C3 gene variant would not be predicted to do well, for instance, with eculizumab. For instance, that's clearly an AP problem. That's not a terminal pathway problem. So I think that even if you can get eculizumab, and if it's the only thing you can do, you'll consider doing it if he recurs, but it wouldn't necessarily be ideal. So I would say that you have a couple of options, and this is just my opinion because I don't work in the same environment that you do, but you either have to wait on his transplant until you are sure you can get an alternative pathway blocker, for instance, available to you. Either that's compassionate or that's actually available in your country, via a regulatory agency. Or you say to the family, for instance, our policy here is we don't wait on anybody. We let everybody have their first transplant, because we don't know. We don't know whether they're going to recur. You saw how many patients didn't recur. So we will classically let people have their first transplant. It's if they recur, and then we won't let them have the second transplant as easily, if you will. But I think it's just a good discussion with the individual and say, you may have high risk for recurrence. We do not currently have an agent that we believe will stop your complement pathway activity, normalize your C3, normalize your production of breakdown products, et cetera. And then you make a combined decision. So for us, if that patient were sitting here, because we do have access to the clinical trials till just recently, but then we do have access to compassionate, we would not do anything prophylactically. We would transplant the patient. We watch the urine blood very closely, like Coyle said earlier about even for ANCA disease. Watch the urine blood very closely. First time you see it, you start worrying about it, and you maybe biopsy. At that point, we would approach a sponsor and say, we would like an alternative pathway disease blocker. But that's not without risk. Because, first of all, you personally don't have evidence for the phase 3, and you don't have evidence for that this patient is going to be fully protected. So you have to make a decision based on what that patient understands and what your team understands and the risks, I think.
Thank you. Thanks. That's really.
Carla, I have a question. In your transplant cohort, did you have patients on eculizumab before they went on to transplant? And was that any different from patients who were not on eculizumab?
No, we don't, again, because I'm in a setting where they restrict my access to eculizumab a lot, actually. So we do not have any transplant patients going in to transplant on eculizumab. I inherited over time a couple of patients who had been on eculizumab for years, transplant patients, by the way, recurred and been on eculizumab for years. So that's how I've acquired my understanding of how, of eculizumab in this setting. But we again, don't do anything prophylactic going in. So I don't know how to tell you if the terminal pathway is soundly blocked when you go into transplant, whether that patient group might not do better. I don't know the answer. I know there are publications, and I shared with you some of them. I know there are publications where some of those patients have been exposed to eculizumab, but it's not been routinely effective, unfortunately. And unfortunately for me, my bias is the 3 patients I inherited have all done very poorly on eculizumab, frankly. The kidney, patient gets started on eculizumab when their allograft IFTA is 20%, and now I'm seeing them a year and a half later and their allograft IFTA is 58%, something like that. So, but that's my bias because there's no trial, right? So we don't completely understand. I think that terminal complement blockade helps some patients beautifully. I'm just not exactly sure how to figure out who that is yet.
And that's a great point. I think, just one, anecdotally, like I've had a couple of patients who were on eculizumab. They didn't do well on MMF and steroids. They were on eculizumab and they got a living related, so no genetic abnormalities, nothing going on. They got a living related transplant and they're doing fine so far without eculizumab post-transplant. So yeah. I don't know if it means anything, but I have no, again, as you said, I have no, method to the madness. I mean, there's no, yes. This is the patient I would use eculizumab. They just happened yes. to be on eculizumab when they got transplanted.
Yes.
So can I ask a more philosophical question to end the session? Recently, just as of yesterday, NEJM published a use of recombinant ADAMTS13 to treat ADAMTS13 deficiency mediated TTP. Why are we throwing a generalized bomb in a disease that perhaps now we can identify a few genetic deficiencies or mutations? Recombinant factor H is being studied to treat macular degeneration. Would that have a role in some of the C3 GNs, and rather than giving them immunosuppressive agents, similar to hemophilia or some of the other hematologic diseases? So just putting out there recombinant, factors, therapy on a weekly basis, on a monthly basis, rather than giving them immunosuppression and complement inhibition. What are your thoughts on that?
So I think I'll just say very quickly, I think it's appealing to think that you can over-regulate or you can finally regulate a dysregulated system. But I don't think we know that if the problem is, if it's deficiency, that's one thing. But if it's a hyperactive system, it's hard to know whether you can re-regulate that by giving factor H. But there are, in fact, sponsors, drug companies who are thinking about that. They're thinking about, can we deliver some extra factor H to the kidney and then therefore protect the kidney from this hyperactivity? It'll be very interesting to see whether it can happen. I think it would work great in a factor H deficient patient. For instance, that patient I said that had the pathogenic factor H mutation, she may very well do absolutely fine with recombinant factor H, for instance, because I believe that is the cause, her deficiency is the cause of her disease. But unfortunately, again, since the genetic abnormalities happen to be the minority of this group, it's going to be hard to figure out whether we're going to be able to, regulate everything sort of generically. That would be my opinion about it anyway. But they must be thinking that it's possible, because I do know that there are companies out there that are working on it.
Well, it's 11:35. We went 5 minutes over to give everybody back their respected time, and I thank Shyam Purva and Carla on this last session. But I really want to thank ISGD and ISN India to really promote this 3-hour session on all 3 topics. Thank you, Koil and Shyam as the co-hosts, and Laurel for really spearheading this from the back end. Please make sure everybody who participated fill out their survey and make sure you give us good ratings. Not just we'll see you next time when we'll focus on nephrotic syndrome. All right, thank you all for joining.
Yeah, thank you, Kenar. I think
Thank
this has
you.
been really a wonderful seminar, and I would like again to thank Kenar for agreeing. We did a good seminar last year and did this thing. This is even learned a lot of things. Carla for excellent talk, Sikha, Koel, Purva, Geeta, everyone for being excellent panelists, and all the delegates who participated in this and took out their time. And it was really, and Laurel for coordinating and providing all the support on back end. And thank you. Yeah.
Thank you.
Thank you.
Thank you.
Thanks.
Thank you so much.